Assalamu alaikum, respected panelists and dear participants. Today's IPDI Cathlab Manual Series 8, we are starting our program with the deepest condolence. We lost Mrs. Rahman Chowdhury, our chairman of IPDI. He is the eminent cardiologist, head of the department of Dhaka Medical College Hospital. She passed away on 2nd December 2020. At least yesterday 12 noon in the Nillai wa Inna June. Professor Wadud lost his father when he was just 11 years old. This Ratnagarbha mother has established her 7 sons, 1 daughter as a true human being through her hardship and willpower. They are all bright stars, their respective fields. Hello, and IPDI family deeply mourn the death of this majestic woman and condolence to her dear family. I welcome our respected panelists, especially our speaker, one of the favorite speaker in Bangladesh, Dr. Aftab Khan. Welcome you to this session. Here, Professor Aniruddha sir, here, Dr. Shams Manwar, Professor Omar Kumar Chowdhury, Dr. Kaisar Musula Khan, Dr. Tamjid Ahmed, Dr. Mahur Rahman, Dr. Khaled Mohsin, Dr. Meskat Ahmed, Dr. Patwary Begum, lots of eminent faculties here. So our participants also benefit from lecture. Also, there are internists also here, Professor Amin and also Professor Ghosh from Chittagong, and another 2 internal medicine, Dr. Zakir Hossain, Professor Zakir Hossain, or Ismail Patwary also joined here. So there is a get together also medicine and cardiology here. So STMI is the most important for the primary physician is the medicine specialist. So we should do dealing with the patients interactively. So I welcome our guest panelists also here. I'm requesting Professor Mohsin sir. Professor Mohsin sir, do you hear me, sir? Professor Mohsin?
Yes.
Sir, yesterday we lost our
mother.
Please tell something, sir.
Really, it's painful for all of us because Wadud is the driving force of IPDA. And definitely with the death of his mother, we are also very sorry and praying to God for his peaceful uh, departure and also Jannat in the future. And also, we'll uh, uh, congratulate Dr. Aftab, who will be our mm, speaker of today's HTMI topics. Hopefully, both we and the juniors will get much information and benefited with this lecture. Looking forward. Thank you very much once again for all the participants and also the speaker. Thank you.
I am requesting our co-chairman, Professor Chowdhury Meskat sir, please, sir. Chowdhury Meskat Ahmed, Professor of Cardiology, BSMU.
Welcome to today's session. Let us go to the main session, the main topics of today's, the management of ST segment, myocardial infarction. Now, can I invite Dr. Aftab to please start his topics?
So thank you so much. It was an honor being here with all of you. And I'll just share my slide. I wonder if is the slide being shared there? Can you see my slide, please?
Yes.
Okay. So I think thank you so much for this honor, Dr. Mohsin, and it really is a loss for Dr. Wadud and all of us. And I think we just pray that the Almighty gives her a better life in the hereafter, and gives Dr. Wadud the sort of the willpower to bear this loss. And I think this is not an easy time for any of us. Now, my topic for today is not something new, and I think rather than a monologue where I just talk about what we do here in India, I think it'd be nice that we have a discussion or a dialogue later on about what are the common, the similarities in our treatment protocol, and the challenges that we face are often similar, both in Bangladesh and in the western or the eastern part of the country in Bengal. Unfortunately or fortunately, India is such a huge country that each sector, for example, the eastern part of the country has a different sort of a cultural, socio-economical, and an economical sort of population as compared to the other parts of the country. For example, the northern part of the country has relatively well-to-do people who have financially more affordable, whereas the western part again has people who also have some degree of affordability. The southern part of India again has people who have a higher level of and where the awareness levels are much greater. So this is what I would prefer, that we just have a small discussion about what the current guidelines are and how I treat our patients here in eastern part of India. And it'd be nice to hear from all of you about how we treat our patients and how the differences and the commonalities are in our treatment protocols. So to start with, I think this is something that we all know, and this has been something that's been described well since many years. And it has been known that a clot in the heart is something that causes a myocardial infarction. For India, this is one of the recent in the sense, though this is a 2008 sort of a paper. This is one of the largest paper which has looked at a prospective analysis or a registry data of myocardial infarctions or of acute coronary syndromes. And many of our studies that or the data that we get are based on this sort of this paper from 2008. So the key differences of STEMI in India that we have realized, and I think this is also the same in Bangladesh, is that amongst the ACS, STEMI is still the commonest form of presentation in India of the acute coronary syndromes. Another factor is that the disease process is usually earlier as compared to the Western countries. So normally we get the disease or the STEMIs are usually in the range of 40 to 50 years, unlike the 60 to 70 years that is seen in the Western literature. And again, we tend to have lower HDL cholesterol. The LDL cholesterol levels are lower, but patients often tend to have higher triglycerides and a higher level of, just 1 second, please. Yeah, so patients usually, sorry there again. So the patients tend to usually have a lower level of LDL cholesterol, but they tend to have a higher level of triglycerides. And this is something that is unique to our Indian subset. And the case fatality rates are also higher in STEMI in India. So this is something that is the data that we've got from these registry that we have done. And these are the other data that we have right from over the period of time. So these are smaller data. So the CREATE, which was the largest one in 2008, we have these other registries from different parts of the country. So this is Kerala is from the southern part of India, where again, we find that the presentation of the first medical contact with ACS. So when you look at the overall, it's usually around 8 to 10 hours. So once the patient has chest pain, the first medical contact is usually pretty slow. So it's almost 8 to 10 hours. Whereas, as I said, Kerala, which has a higher literacy rate, you can see that it translates into a better or an earlier contact time. So the contact time where the patients reach the hospital or have a first medical contact is usually smaller or earlier in the southern part of the country. Whereas in overall, in the other parts of the country, it's usually pretty pathetic. And when you look at this data, when you look at the first medical contact as compared to the global registries, and here you can find out, this is the onset of symptoms to hospital admission. The CREATE registry from India is almost 300 minutes. This is pretty bad. And this is where we are all working towards to try and increase awareness so that patients come to the hospital earlier. And this is the global data, European surveys and the US registries, where it's usually much earlier. Now, what are the reasons for delay in STEMI care? And the most important one is the lack of awareness of symptoms. Majority of the patients still in our current era would think that this is all gas. And it will be very surprising that even when patients come to the hospital, they would not be able to understand or realize that this is cardiac or this is a myocardial infarction. We still have a lot of trouble to explain to them that this is not gas, this is a myocardial infarction. Patients' inability to appreciate the gravity of the situation. Fortunately or unfortunately, our MI patients are still talking, unlike a stroke patient who stops talking. So it's very difficult for patients to understand the gravity of the situation. And of course, there are the other problems that happen, which happens in terms of delay in ambulance responses or delay in transport or poor peripheral primary services. But of course, economic factors and delay in patient's consent also make a difference in the delaying the door to balloon time. So even when the patient reaches the hospital, knows that there is a myocardial infarction, sometimes we are not able to take these patients to the cath lab because of hospital protocols where they have to make sure that the patients understand the economic financial burden, or there is a delay sometimes in the patient's consent, where the patient himself, because he's sick and he's not able to give a consent, the next of kin, which is often a family member, or it is a friend who gets him in, may not want to take the onus of responsibility because of the economic factors that often go associated with this treatment of this disease process. This is an old slide which we've often seen right from our undergraduate days. And you know that when the coronary anatomy, when the lumen of the coronary artery is blocked partially, you have what we call as a non-STEMI, where you have or an acute coronary syndrome or a non-ST elevation MI. Whereas when there's a complete occlusion of the lumen, you get what is known as an ST elevation MI. Well, this was what we knew earlier, but now this has been more complicated, and now the guidelines have talked about a type 1 ST elevation MI or a type 1 non-STEMI. And well, the earlier old definitions of Q wave, non-Q wave MIs have all been sort of dumped. And now we start talking in terms of more complex things. Well, why is this important for us to understand what is type 1 or type 2 myocardial infarction? Well, again, this has been reclassified into type 1A, type 1B, type 1C, type 1D, based on the pathophysiology. So if you had a plaque rupture, we'd call it a type 1A. And this is something that we commonly see, most commonly in all our patients who present with STEMI. Well, spontaneous coronary artery dissections can also present with occlusion of the lumen. You can have embolism in the coronary arteries, which can occlude the lumen, or you can have vasospasm. So these fall into the category of type 1 myocardial infarction. And these classifications were made based on the universal definition of myocardial infarction in 2018, which are now classified into 5 types. Type 1 is the commonest one that we're talking about when we say STEMI. We are usually talking about a spontaneous myocardial infarction, which is often related to a plaque rupture or an ulceration or fissuring, which results in coronary thrombosis and an occlusion of the lumen. Or it could be because of a demand-supply mismatch, which is known as a type 2 myocardial infarction. Or patients who have death, when patients are brought dead or they have an autopsy, and you find that there is a death without a definite marker. This is known as a type 3 myocardial infarction. We also know that post-PCI, you can sometimes have complications where there may be a rise of biomarkers. You could close off certain branches of the arteries. For example, if you're doing a plasty of a circumflex, if there's one of the obtuse marginals that closes off, there would be a myocardial infarction. And this is classified as a PCI-related myocardial infarction. And there is something known as a stent thrombosis, which is post-PCI. If your stent closes either because of a technical reason, you've not deployed your stent well, or there is an antiplatelet related issue where there is, say, a platelet aggregation problems, There is sometimes with clopidogrel, there is platelet resistance. Well, all this could produce stent thrombosis, and this produces a 4B type of myocardial infarction. And post-myocardial infarction, post-bypass surgery myocardial infarction is classified as type 5. Now, why this is important is that when you say MI, we are most likely speaking about spontaneous MI, but we need to understand that there are other diseases also which could also produce myocardial infarction, and all of these need to be maybe treated differently. For example, a CABG related myocardial infarction would be difficult to be treated with thrombolysis, whereas a spontaneous myocardial infarction, well, we could probably give thrombolysis in the place where the facilities are not available. In a patient with a stent thrombosis, again, well, you may think whether we should give a thrombolytic therapy or we should give a GP2B3 inhibitor, and one may need to look at different pathophysiologies to decide what treatment we need to give. So therefore, this universal definition of myocardial infarction, which was introduced in 2018, has made it a little difficult for us, but one needs to understand that your diagnosis is often based on the clinical scenario, and it's not one myocardial infarction which can fit all the diagnosis. Now, for our preview of talk, what we normally depend on in India is the guidelines which have come up. So there have been the STEMI guidelines, which were in 2017. This was a consensus which was formed by the STEMI India, the Cardiology Society of India, and the Associations of Physicians of India. So this was a guideline in 2015. In 2017, again, there was a Cardiology Society of India, a position statement which talked about how to treat our patients. And we also depend upon the ESC guidelines, which also give us some guidelines about how to treat our patients with myocardial infarction. But again, as I said, this is something that we all agree, the class 1, class 2, class 2A and 2B. 2A, where there is more evidence in terms of doing it. Class 2B, well, you're not wrong if you do it, but there's less evidence. And class 3, where people would say that there is more harm than benefit. And this is something that we do not usually recommend. And there are these 2017 guidelines, and we'll come to this again. This is the ESC guidelines, which have had changes. So guidelines change over a period of time. In 2012, what was a radial access, which was said to be preferable, one could do it or not do it. Whereas now in 2017, we have data to say that if you use radial access in a patient with a STEMI, you probably have less mortality relating to bleeds from the access sites. Again, DES versus BMS. Now there is data to say that DES is probably better. And if you have to use a stent, it's always preferable to use a drug-eluting stent. There is initially it was revascularization. We would only do only the culprit artery and not do the others. And now we will discuss this. There's other data to say, well, you could probably a 2A or a 2B recommendation touch the null culprit artery also. And therefore, as this basically tells us that guidelines change over a period of time. What we are talking about now may not be something that a year down may be the same. So this is what is the guidelines. And for our hospital purposes, for our staff and for our emergency, we have the clinical practice guidelines which we release. And in 2019, this was the guidelines from the Apollo Gleneagles Hospital. And this is something that patients, I mean, not patients, but all the health workers, whether it's the emergency doctors or it's the nurses, they have this on their app also, and they can download it and use it to diagnose and to treat these patients with myocardial infarction. So in the current guidelines as compared to the previous guidelines, as I said now, we now have a clear differentiation between myocardial injury and myocardial infarction. And for myocardial infarction, you need to have an ST elevation where you have to have it secondary to ischemia. So when you're saying STEMI, we are talking about the type 1 myocardial infarction. Again, the previous guidelines did not talk about the formatted response to a chest pain. So if there's a patient who calls up into the helpline number for chest pain, we need to have encouraging the ER doctors to sort of help the patient out to understand which is the closest access time to them, how far they are from a hospital where they can either get primary health care, and to identify how these patients should be basically tackled and made to reach a healthcare facility system. So this is the normal protocol that we follow at Apollo. The patients usually, they have a helpline number that is 1066. They usually could call up there. They would ask for ambulance. The medical coordinator there would then help the patient to understand where they are, and they would sort of make a diagnosis based on their symptoms, whether they have profuse sweating, they have vomiting, shortness of breath, whether they've had chest pain which is lasting more than 30 minutes. In case they have a chest pain which is similar or typical of cardiac ischemia or an infarction, they would tell them to take an aspirin on telephonically. And we know that aspirin is a safe drug which usually has mortality benefits. They'll also send an ambulance on the scene, or they will help the patient to get an ambulance, and then they will reach an acute coronary syndrome service care, which if it is close to 20 kilometers radius, Apollo Gleneagles becomes the hub, and the other, or if the patient is far away, he's referred to one of the spoke centers from where he could be probably treated eventually. So again, there was no mention earlier of the hub and the spoke model, but now in 2019, we have now set up a hub and the spoke model where the patients are referred, either asked to come down to the hub or they are referred to one of the peripheral spokes from where they can get the initial treatment and then be referred to the central hub. The previous guidelines also did not talk about this the reinfarction data, but now we know that the CPK rise of more than 20% in the value of troponins between two samples 3 to 6 hours apart, with a patient not having a chest pain relief or STs not settling, well, that's a place that we should start suspecting reinfarction, especially in a patient who's undergone thrombolysis. So this is something that we have introduced in the guidelines. And well, again, the guidelines have now become more strict about how early a patient should receive a first medical contact after the patient has sort of complained with chest pain. So once the patient has complained of chest pain, it's important that we try and get an ECG as early as possible. And this is something that we try and get within a period of 10 minutes. If the patient has to be referred to a hub center or to the primary PCI compatible center, well, he has to get there within a period of 90 minutes, and he should be taken a door to balloon time. Once he reaches there, he should be in a cath lab and his arteries opened up within 90 minutes. Or if he has a non-PCI center, the delay should not be more than 120. So if he can come to a hospital where PCI is possible, he should have his artery opened within the 90 minutes. If he's from a far away place, he should reach a hospital within 120 minutes. So 1.5 hours or 2 hours, that's the maximum. If the patient is from a non-PCI center, he has to sort of reach the hospital to a door to balloon time of 120. And this additional from 90 minutes, we can come down to 60 minutes from the door to balloon. This is because once the patient reaches a non-PCI center, he gets the initial therapy done, and from the non-PCI, once he's been transferred, he can sort of activate the cath lab, and the team can be ready so that we immediately take the patient and do the plasty and open up the artery within a period of 60 minutes. If the patient is to be having a thrombolysis after the first medical contact, he should get a thrombolysis once he reaches a hospital within a period of 30 minutes. So these are timelines which have been formulated by the ESC also, and most guidelines talk about these timelines, and we'll speak about this as my talk progresses. So this is what it is. As there's an onset of chest pain, I think as the patient comes directly to a PCI compatible center or a PCI capable center, it's important that we take the patient and open up his arteries within a period of, or a door to balloon time of less than 90 minutes. So if he comes directly to my place at Apollo, what we do is take and do an angioplasty within a period of 90 minutes. This is something that we have to achieve. If for some reason the patient cannot be achieving this less than 90 minutes, we need to look at alternative treatment. So if he comes to the cath lab, to the hospital emergency, and we find that all the cath labs are busy, then we may have to think of other protocols. And if the patient cannot be taken up within 90 minutes, we may have to shift to something which is known as a facilitated angioplasty that we'll talk about in the future. If the patient is in an ambulance and he goes to a non-PCI center and he's being transferred, the total time should not exceed 120 minutes. So here, within a period of 120 minutes, his artery should be open. And of this, the travel time should not be more than 60 to 90 minutes. So in India, when we have, or especially in Kolkata and in West Bengal, when we have traffic problems, I think the similar problem would be there in Bangladesh also. We usually have kept our hub to not within more than 20 kilometers. So a patient has to be within a 20-kilometer radius for him to reach within a period of 90 minutes to be able to get a door to balloon time of less than 30 minutes. So this total time should not exceed 120 minutes. And if the patient goes to a non-PCI center, he should get a thrombolysis within a period of 30 minutes, put on an ambulance if the travel time is less than 60 minutes, and again should have a door to balloon time of less than 30 minutes. So again, 30 minutes, 60 minutes, and 30 minutes. So within 120 minutes, we should have a door to balloon, the wire crossing. So from the onset of chest pain or first medical contact, if it is possible to have an angioplasty within 120 minutes or less than 90 minutes, only then it makes sense to have an angioplasty done. If the patient's travel times are going to be greater, then it is always preferable to thrombolyze this patient and then shift the patient rather than shifting the patient immediately. So these guidelines have put that as 120 minutes. So this 2 hours is something that is very important for us. And as I said, if the pre-hospital or the nearest hospital is an option, then we often ask the patients to be thrombolyzed in the spoke hospital and then transferred, which is often known as a pharmacoinvasive strategy. Of course, this is sometimes okay, but then there are certain problems which we'll discuss as we talk along. So the guidelines have also talked about, as I said, the radial access, and this is the guidelines that we have for our healthcare workers at Apollo. We have also talked about stenting, which is a good thing, drug-eluting stents, as we said already, and of course, the key take-home messages from our current practice guidelines to our healthcare workers at Apollo is that the STEMI mortality still remains high. So we still have a very high mortality, more than 10% at 30 days. The in-hospital mortality is 10%, 30 days is almost 12%, and one-year mortality is almost 18 to 20%. Patients who receive thrombolysis or PCI or fibrinolytic, some form of reperfusion, definitely would have a better survival compared to patients who do not receive any reperfusion. Patients who can get an angioplasty in the index case definitely do better than fibrinolysis, and this is the data that is from other registries also. We have had a diagnosis of myocardial injury versus myocardial infarction. Myocardial injury is when you have myocardial cell death due to non-ischemic causes, and to diagnose myocardial infarction, you should have one of two of the three. You should have a chest pain which is consistent with onset of ischemic origin. You should have ECG changes of ST elevation. You should have a cardiac enzyme which is elevated. Either that, if you don't have these, then at least an echo finding. For example, if the ECG changes are not very specific, if there's a wall motion abnormality suggesting a regional wall motion, or if you can diagnose an intracoronary thrombus by an angiography. Well, this is something in the cath lab that we do. So this is what will be diagnosed as a STEMI. So this is something that we have already discussed, and how a STEMI is going to be different from ACS or non-STEMI. So my talk is going to be limited to the ST elevation MI, because we know that non-STEMI and unstable angina, these have different treatment protocols, and I'll not be really discussing about this. So my talk is going to be limited to STEMI management. So again, coming back to diagnosis of STEMI. So as I said, we need to have 2 out of 3, usually an ST elevation of 1 millimeter in 2 contiguous leads, onset of left bundle branch block in a patient with resting ECG, along with symptoms of chest pain. So if you just have an onset bundle branch block, which is new onset, which this becomes a problem because many times patients don't have their old ECGs. We don't know if it's a degenerative left bundle branch or it's a new onset of left bundle branch block. So just a bundle branch block may not be enough for us to say that the patient has myocardial infarction and thrombolize or take these patients to the cath lab. If the patient does not have symptoms, we usually are not so keen to take these patients up. But if the patient has a new onset left bundle branch block, if he has a past ECG which did not show a left bundle branch block, and along with that, the patient has chest pain, which is classical of an ischemic type, and he has a rise and fall of cardiac biomarkers, then this left bundle branch block can be assumed to be because of a myocardial infarction. These are things that we all in cardiology would know, and these are the various leads that we look at. But for our healthcare workers and for the primary healthcares, what we have done is sort of made a bar diagram like this, so that the healthcare workers would just look at the ECG and say which leads are elevated. So they're just told to look at the ECG and tell us which leads are elevated. For example, if he tells me that V5, V6 and the orange colored leads, this is the orange colored bar, V5, V6 and 1 is elevated, I know that we are talking about a lateral myocardial infarction. If the healthcare worker tells me that it's V1, V2, which is only elevated, we know we are looking at a septal lead. If it tells me that 2, 3 AVF are elevated, so we ask them to look at these boxes and tell us whether it's the blue box, which is showing changes, it's the green box. And this makes it easy even for an ER doctor who may not, as we all understand, may not be very familiar with interpreting ECGs. But if he looks at these ECGs, he can quickly identify and tell us whether it's an inferior wall infarct, or it's an anteroseptal infarct, or an anterolateral infarct. And this sometimes helps us to identify the diagnosis of myocardial infarction. Well, unlike left bundle branch block alone, we know that right bundle branch block also is seen in patients with anterior myocardial infarction, possibly even more commonly than a left bundle branch block. And again, it's important that we don't differentiate between left and right bundle. We also look at the symptoms in these patients. Sometimes in a right bundle branch block, it's easier to diagnose ST elevation as compared to left bundle branch block. And any patient who has, say, a pacemaker beat or a right bundle branch block, it's important that we don't go and thrombolize them without being sure, because sometimes the right bundle branch block, you may have some ST depressions, which may be wrongly interpreted as an ischemia and thrombolized. So unless there is secondary changes, which the normal ST changes which we see in V1 to V4 in right bundle branch block, the T wave inversions should not be just interpreted as infarction, and the patient should not be thrombolized. And therefore, we normally tell our healthcare workers when they look at broad QRS ECGs to be a little careful when they diagnose this. For the left bundle branch block, the Zaragoza criteria have stood the test of time. They've been used for a long period of time. And in patients with a left bundle branch block, the criteria look at more than 1 millimeter ST elevation in patients with concordant limb leads. So this is say a limb lead 2. So in this limb lead, when there is a left bundle branch block, normally you would expect a T wave inversion or a secondary changes. But if this patient had a T wave upright, and if the elevation was more than 1 millimeter in a concordant lead, then we would classify this as a myocardial infarction. The second thing is if there's a depression in a discordant lead. So for example, V1, V2, we'd normally get a depression in a patient where the T is normally upright, then this is again taken as a sign of infarction. And in sort of a lead V1, sorry, this is in the lead V1 to V3, but in a lead V1, if you get an ST elevation, normally with a lead V1, normally you get an uptake of the T wave, which usually goes up. Unless you have a more than 5 millimeter lead elevation, this is not taken as a myocardial infarction. So you have this scoring system where you look at concordant leads, we look at discordant leads, and we look at ST elevation or ST depression, and one then makes a diagnosis along with the history of symptoms to diagnose whether the patient is having a myocardial infarction. This is a small algorithm that we again have to diagnose whether the patient has a myocardial infarction. And again, as I said, many times the patients may not have a previous ECG, and it's not just the bundle branch block. So just having a left bundle branch block without having sort of instability and chest pain, without having any other evidence of ST elevation or the criteria that we just described, well, we do not diagnose a myocardial infarction and thrombolize these patients. This patient may be having unstable angina or a non-STEMI. And if you thrombolize this patient thinking it to be a myocardial infarction, you could probably do more harm. So therefore, if you don't have the symptoms that we normally talk about, it's important that we sort of risk stratify. And then possibly if there's still a confusion, then rather than thrombolysis, taking this patient for a angiography and then taking a decision is probably a better choice. Again, the pitfalls in diagnosis, as I said, elderly women or elderly patients, women diabetics could also have non-diagnostic ECGs in the initial presentation. But again, if the patient has a symptom which is very classical, and especially if the patient presents at the night, well, it's important that we keep these patients, do a repeat ECG after some time. We do not tell up our emergency doctors to send these patients home. So any patient who comes in the middle of the night with chest pain, well, if this patient has come to the hospital with chest pain, even if the ECG is non-diagnostic, it's always wise not to just give this patient antacids and send him home, because the initial ECG may not show any changes. And it has happened many times that the patients have been sent home and the next morning they come up with a full-blown infarct. So any patients in a hospital who comes in the night is made to stay back. We take another ECG and then make a diagnosis rather than sending the patients home at the middle of the night. So this is what is important for us, the pre-hospital management also. Well, any patient with STEMI should be given a chewable aspirin and not the entry-coated aspirin. So we make sure that it's not the entry-coated aspirin that patients are chewing, but it has to be a chewable aspirin or the Disprin, which is a dissolvable aspirin. And they're also asked to take clopidogrel. These patients are transported to a hospital. We tell these patients not to go to a clinic. So many times the patients want to go to a doctor chamber nearby. And after he's had his ECG and had this chest pain, if they call up the helpline number, they're always asked to go to a hospital which is close by, rather than going to a clinic and standing in a doctor's line. The STEMI network again has looked upon to diagnose patients with STEMI and also to identify how to treat these patients. So again, this concept of hub and spoke is something that is very important in the current era. The initial treatment again is similar that I think always area of the world you do. We get pain relief. We need to establish reperfusion and we need to treat complications. This is a small management protocol that we follow. The decisions is the mode of reperfusion, whether it's thrombolysis or primary PCI. If it's a thrombolysis, again, which look at which thrombolytic we should give. And if it's and we then talk about after the thrombolysis, when do we transfer these patients to primary PCI? Or not primary PCI, sorry, we look at a pharmacoinvasive approach, or when do you transfer the patient to a tertiary center for an angiography and if necessary, a revascularization. So should we immediately transfer or should we transfer later? So coming to the mode of reperfusion, I think we all agree that there are two forms. There is the thrombolysis that we know. The advantage of thrombolysis is that it's easily available. The disadvantage is that it has a recanalization rate, especially if you're using streptokinase, which is the commonest sort of a thrombolytic agent in India still, because of its cost factor. The disadvantage is its recanalization rates are pretty poor. It's only 60%. We also know about the fact that you can have, it's a non-selective thrombolytic and therefore non-clot selective, and therefore you could have hemorrhages also, and you can have bleeding contraindications also. And we know that primary angioplasty definitely scores over fibrinolytic. Multiple studies and multiple trials have shown that there's a greater survival benefit. The survival rates are almost more than 90% less as compared to fibrinolysis, and there is a mortality reduction both in hospital and long term also. And this is data that is commonly known, less death and myocardial infarction with PCI, both, and recurrent ischemia, recurrent MIs are much lesser when you do PCI rather than thrombolysis. Now, angioplasty definitely scores, as we know, over thrombolysis. Though the initial cost is high, and this sometimes may be a different factor, we know that it is more cost effective in the long term. And this is something that we realize and we ask our patients to understand. If you can preserve the myocardium, then these patients will have a better long-term outcomes. If you lose your myocardium, then repeated heart failure hospitalizations, arrhythmias, these are more common, and the patients often have, even though they have saved initially, they always have a higher cost because of repeated hospitalizations. And again, we need to understand that, well, though primary PCI is definitely an advantage, well, in a country like India and possibly Bangladesh, there is a challenge because of the fact that you need to have institutions that are well equipped. And of course, we need to have operators also who are there, even in the remote areas, to help us with this form of a treatment. So the fibrinolysis sometimes may be something that we give. Now, when it comes to the initial 3 Rs, we know that there is data to suggest that the early presentation, if the first contact with a medical contact from the onset of chest pain is very early, within 3 hours, then the outcomes with an angioplasty or a primary or a thrombolysis may be almost equal. So very early thrombolysis may be as good as a primary angioplasty. So many times we often tell our patients not to be transferred if the patient has come very early, and we ask the spoke hospital to thrombolyze this patient, because sometimes transfer times may be longer and we may miss out the benefit that these patients may get. The invasive strategy or a primary PCI is often preferred when there is a skilled cath lab, when again patients have a high risk STEMI, when they are in cardiogenic shock, when they are in heart failure, or if there is a contraindication for thrombolysis, or again a very late presentations, more than 3 hours, more than 12 hours, something that again, as we saw earlier, is not very uncommon in a country like India. Or if there's a diagnosis of STEMI is in doubt, and this is what I was saying, if the patient has a paced rhythm, if the patient has left bundle branch block where we're not sure of, sometimes rather than thrombolizing, it may be better to take these patients into the cath lab and look at the angiogram. But again, the real world scenario, as we've all discussed earlier, this is something that we run the risk of. So if you are sending a patient for primary PCA, we sometimes may delay and we may end up having less muscle saved. So unwanted delay may reduce the success of myocardial salvage. And therefore, even though the guidelines talk about it, we needed to find a solution. And therefore, this in India and probably in Bangladesh also, what works best is possibly a pharmacoinvasive strategy. So this is a strategy that has found a lot of favor in India. And this is a strategy that has in many other countries also, in many trials also have been found to be probably better than just thrombolysis alone. And it's a strategy in which what we do is to give a thrombolytic therapy in a patient who cannot be shifted for primary plasty, either because of usually a delay in transfer, or because of late presentation, or a far off spoke hospital where there may not be a facility for primary angioplasty. So once the patient reaches this place, what is done is that he receives a thrombolytic therapy to achieve a restoration of blood flow. And then once the patient has received a thrombolytic therapy, the patient is then transferred to a place where an angiography can be done. And then usually within a period of between 3 hours to 24 hours, this patient then undergoes an angiography, and if needed, then an angioplasty. Again, an important thing is something that we would probably discuss after my talk, is that in India, sometimes you're finding a lot of young patients who come with myocardial infarction, where the pathophysiology is often a thrombus rather than an underlying plaque. So many of these young patients in the age of 30 years who come with myocardial infarctions, once they have had a thrombolytic outside, when they come for an angiography and then we do an angiogram, we often find that the arteries are completely clean. So we don't find anything left behind. So thrombolysis also in young patients may give us a good result without leaving back any underlying plaque. And especially in the young groups, this may be sometimes a very good approach. So this is an approach that has found favor in India. And this is found, again, we've done, these are the trials that have been done in India, the STEP-MI trial. This is again from the southern part of the country, where this is a trial which has compared the tenecteplase facilitated PCI versus primary PCI in Indian patients. And again, it found that the facilitated PCI was as good or probably better than primary PCI in Indian subsets. And there were other articles also from other experience. This was an experience from the northern part of the country, from Lucknow, where they again compared the delayed routine pharmacoinvasive approach versus the primary plasty approach. And again, this was the same thing that showed that probably there may not be much difference in the outcomes if you do a pharmacoinvasive approach. The guidelines also talked about this, and this is something we talked about earlier also. The patient should have an early contact, get an ECG done early. And this is something that we have talked about in our hospital guidelines also. 120 or 2 hours is the golden time. If you can get a patient within 2 hours to the hospital and get an angioplasty done within 90 minutes, so the total time is not really more than 2 hours. This is something that is favorable. If the patient is far away and he cannot reach the hospital and get his complete angioplasty done within a 2 hours period. So we are talking about the transfer time, we are talking about door to balloon time, everything which is less than 2 hours, then it is better to get the patient there, but to thrombolize this patient there and then shift the patient for a facilitated angioplasty at a later time. Now, for patients who have to receive thrombolytics, as I said, probably a good old drug, there are certain problems with streptokinase. There is a patency rate. The patency rates are a little lesser as compared to the second and the third generation thrombolytics, where the patency rates are better. The other problem with streptokinase is that it is dose adjusted. So, sorry, this is not non-dose adjusted. So sometimes we've seen that when you use another drug, the altiplase. So this is a drug which is also known as the first generation or a second generation, sorry, the second generation drug. The disadvantage of streptokinase is that it is non-dose adjusted. So you just give 1.5 million units. Now, some people, and we also tend to think that, well, it looks a bit unique to say that we give the same dose in a 40 kgs man who comes with myocardial infarction and the same dose in a 120 man who comes with myocardial infarction. So this looked a bit funny, but this is something that we've been using for a long period of time. And therefore, this is a drug that was in work, but now we are all moving away from this drug. Altiplase also had an effect that you could give it as a bolus and a loading. But the problem with altiplase is that when you used to suggest this to our spoke hospital doctors, patient used to be transferred, and during the transfer, the bolus used to be fine, but the infusion rates often used to be way haywire. So the infusion rates used to be really either more or sometimes lesser than what was needed. And therefore, what is most important or what is found most value with us is either tenecteplase, which is a single shot based on your body weight, or retaplase, which is again non-body weight dependent. You just give 2 boluses of 10 units, 30 minutes apart. So these are 2 drugs which are now most in favor in our pharmacoinvasive approach, and we are now moving away from streptokinase and altiplase. Again, cost does become an issue because these 2 are more expensive than streptokinase, but there's a huge benefit in terms of patency rates. You can see that we often achieve patency rates almost of 80% when patients have received either retaplase or tenecteplase as their thrombolytic agents. Again, as I said, these 2 are single boluses. This is a bolus injection over 5 seconds, and these are 2 bolus registered 30 minutes apart. Altiplase has a bolus and an infusion, and this sometimes in a calculation by the doctor or the healthcare professional sometimes goes haywire. And this is something that we've seen. We've had patients who've come with huge dosages and had bleeds, or patients who had pediatric dosages received in an elderly patient and really have had not the good result that we normally expect. So coming back to the patients who present late, and this is something again that we see very common. Again, what do you do with these patients who present very late, more than 24 hours? This again needs a careful assessment. If these patients are still unstable, so if they have heart failure, hemodynamic instability, if they have ongoing ischemia, then again they go for an angiography and revascularization. But if the patient is not really having a high risk and the patient already had infarction and the myocardium which is already dead and gone, and the patient is stable, well, data tells us that there's no point in doing an angiography and opening up occluded arteries more than 24 hours. So if you do an angiography and you find that your artery is 100% occluded after 24 hours, there is no data to say that we should do an angioplasty because you may not get any benefit. The myocardium is already probably dead. If you do an angiography and you find that there is a trickle of flow that is going through, which sometimes happens when you have had a thrombolysis, the artery is not 100% occluded, but say subtotally, there's a 99% occlusion and there's a TME2 flow. Then in these patients, there is a 2B recommendation that you could still do an angioplasty and get some benefit. So late presentations, you look at the angiography But then do we take all these patients for angiography? The answer is no. If they are stable, we just wait on, do a viability study, find out if they have a viability myocardium. If they have a viability study which shows viability, then you can do an angiography. If they have dead myocardium, well, we just use the best medical management. Again, these are the time frames that we have already talked about, the 3 hours, 3 to 12 hours, and more than 12 hours. And again, all of this is important to realize that time is muscle. And this is something that I think all of us have realized over a long period of time. This again, we have re-emphasized in our guidelines, the 2 hours period that we have talked about. And this is again the same message that we are trying to say in a patient with 2 hours is what we have to really from a non-PCI center also. And this 2 hours is the total sum of transfer of a door to balloon time and the wire crossing. So everything together should be 20 minutes, 120. And if it's a direct approach to the hospital, then less than 90 minutes is something that we're looking at. Reperfusion, well, we know that primary PCI is definitely recommended over fibrinolysis, something that we have just discussed. Early angiography is something that we have again said within 24 hours. Late PCI, we've also discussed this more than 24 hours. Well, more than 48 hours, if you have asymptomatic patients, well, there is no point in doing opening up these 100% occluded arteries. The timings are also there in the ESC guidelines that we've discussed. And again, these are the times that we are talking about, 0 to 3 hours, where you could give both fibrinolysis or PCI, possibly with equally good results. More than 3 hours, probably PCI is better. And more than 48 hours, well, of course, you just need to assess and then take a decision. Do not rush for a primary PCI if the patient is not having symptoms or if having any other issues. Well, again, this again talks about the changes in recommendation. So this is something for people who have been doing the PCIs. So there's again, we have realized that radial access is something that we talked about. It's important to use drug-eluting stents. There was a debate about doing a complete revascularization in one go. Should we touch the non-culprit artery or do only the culprit artery? There is an issue about doing a thrombus aspiration. So this debate about doing a culprit artery versus a non-culprit artery has gone a complete change. Initially, it was a class 3 recommendation. So 2012 guidelines had talked about if you were doing a primary angioplasty and you did the non-culprit artery, you were doing harm to the patient. There have been certain studies which have said that if you can safely do it, it has been now upgraded to a class 2B recommendation. So if you think you can do it, it's not a class 3 anymore. But again, there are certain things that we'll discuss. If the patient has cardiogenic shock, again, there are different recommendations. Thrombus aspiration, again, initially was told to be beneficial. Now they have put it as class 3, but again, I think we can discuss about this in our cath lab. We don't take it as a class 3. And if you see a huge thrombus burden, we still, of course, do a thrombus suction. We knowing that it may not improve the patient's mortality, but it does definitely improve TIMI3 flows, and it helps us to get a better TIMI3 flows. And again, early hospital discharge is something that we're looking at. So the infarct-related artery strategy, as we said, primary PCI of the infarct-related is to be done. The non-culprit artery, again, is something that we should think about. And if you want to do it, well, the guidelines normally talk about not doing it right at that period of time, but staging it in the sense that if you've done a primary angioplasty, you don't do the non-culprit at the same cath lab time that you're doing the primary angioplasty. But pre-discharge, if you see another artery, for example, if you've got an occluded LAD and you've done a primary angioplasty for the LAD, you probably may not need to do the angioplasty of a critically blocked circumflex in the same go, but probably pre-discharge after, say, 1-2 days before the patient is ready to go home, you could get the patient back into the cath lab and do the circumflexplasty in the same hospitalization. So the same index case may not mean the same procedure, but it may mean the same hospitalization. And that is what has been included in the guidelines also. And especially in patients with even cardiogenic shock, they say that non-RI PCI during the index procedure should be considered patients with cardiogenic shock. And this is a class 2A recommendation. This is something that is a different ball game already. Cardiogenic shock, well, we could do a culprit. We could do culprit plus trace revascularization, or you could do an immediate, you do the multi-vessel PCI. Well, we really don't know what is the best option, but most of the data is now favoring doing a culprit lesion alone during even a cardiogenic shock, and then doing a staged revascularization before the patient goes home. So staging does not mean that staging in after a month or staging after a period of say 6 weeks. You could stage it before the patient goes home. There are advantages of doing a staged procedure as compared to doing an immediate procedure. The most important of this is the contrast load. And this is a difference that was found in the contrast load when you did a contrast, when you did a PRAMI, which was sort of only the primary of the infarct related, whereas the COL-PRIT, which was the data which looked at doing it all at the same time, and you find that there was a difference in terms of the total contrast burden, and therefore the contrast risk of contrast-induced AKI is much greater when in the index procedure itself we want to do a multivessel plasty. So there have been many trials which have been done, and as I said, the data now goes more in favor of doing the culprit alone and doing a staged PCI in the same hospitalization rather than doing the procedure in one go itself. Coming back to the balloon pump and the other supports, the IBP Shock 2 trial has not really given us a mortality benefit. But again, I think all of us realize that balloon pump is one of an important hemodynamic support when you're doing patients with shock. Even though the mortality may not be benefited, well, we know that the procedure becomes that much easier. And again, there have been certain criticism of the Shock 2 trial also. But again, I think in our routine practice, it is one of the good hemodynamic supports. And we also have the Impella in our cath labs now. But again, the cost is exorbitant as compared to the balloon pump. As compared to IBP, Impella is really a very expensive tool. But of course, for those patients where you have Impella, it definitely gives a much better support as compared to a balloon pump. Coming to antiplatelet, and this is something that I think all of us could discuss, and the practical protocols are different in many countries. But the protocol that we normally follow is the ESC1 only. We could use prasugrel, we could use ticagrelor or clopidogrel. Clopidogrel still remains the commonest antiplatelet that is used in our country. And though we know that clopidogrel resistance is one of our problems. So in India, we still have a problem with clopidogrel resistance. Well, testing of platelet inhibition is really not possible. And many times these patients come back with stent thrombosis, and only then we realize that this patient has clopidogrel resistance. So we are now moving from clopidogrel to mostly ticagrelor. And this is a good drug, rapid onset of action. It is reversible, and it gives a more complete platelet inhibition as compared to clopidogrel. Again, cost becomes an issue, but again, we have a lot of generic drugs of ticagrelor, which are more cost effective also. So even though the guidelines are more in terms of clopidogrel, patient use in the peripheries is still more of clopidogrel, but in patients who have had a PCI or in patients who are affording, we still are switching on to ticagrelor. Prasugrel is also a good drug, but we stay away from patients who are elderly or patients who have a previous neurological event. So again, these are the loading dosages. We usually give it aspirin in high dosages. The dose of clopidogrel is 600 milligrams. So when you're taking for primary PCI, you would use 600 milligrams and then follow up with a maintenance dose. The prasugrel dose is also 60 milligrams followed by 10 milligrams. Ticagrelor also is given in as 180 milligrams and then 90 milligrams twice daily. When patients are taken for primary PCI, and if you have a huge thrombus burden, because this clopidogrel takes a little long to act, it's a pro drug. And therefore, in those patients, when you see that there's a thrombus burden, we could use either the selective apiximab or the non-selective GP2B injectables, eptifibatide and tarifaban. And these sometimes improve our Tamiflu rates also. Use of antithrombotics, well, most of the times it's unfractionated heparin, but sometimes when we have Clexane or enoxaparin that has been used, we sometimes use IV enoxaparin also in our procedures, which is a 2A recommendation. So it still is mostly unfractured heparin during our procedures. The dosage is usually 70 to 100 when you're using no GP2B3A. But if you're using one of the tarifaban, or if you're using eptifibatide or apiximab, then it's usually a lower dose of unfractionated heparin. When the dose of fibrinolytic, as we said, well, fibrinolytic therapy is to be used, but we tend to use more of a fibrin-specific agent rather than the streptokinase. And in these cases, what you need to do is that we normally use clopidogrel. So when you're giving a thrombolytic agent or fibrinolytic agent, well, the recommendation is not to use so much of ticagrelor, because the data is not so great about the role of fibrinolytic agent along with ticagrelor. Though there is some recent data which says that yes, you could safely use it, but we still are more comfortable to tell our patients who are receiving fibrinolysis in the periphery to receive ticagrelor, not use ticagrelor, but clopidogrel when they're using a fibrinolytic therapy. The next dose of ticagrelor when they shift to a primary PCI is that we usually make sure that we give ticagrelor only after a period of almost 6 to 8 hours after the patient has received fibrinolytic therapy. So we don't load either prasugrel or ticagrelor very early after a thrombolytic therapy. And it'd be nice to hear from all of you also what your recommendations are. Again, these are the recommendations for how to transfer. And I think these are common in all our countries. I'll just skip these slides. The contraindication to fibrinolysis are well known. I think this is something that we also explain to our patients, and they must consent to understanding this. The rates of the intracranial bleeds are definitely lesser once we have started using the more selective thrombolytic agents. They used to be much higher when you're using streptokinase. Again, it's important that we realize that patients do not undergo an arterial puncture when they're on fibrinolytic therapy, something that our ER doctors have also been told, and especially not a groin puncture. In case the patient is in shock and needs an arterial puncture, it always should be a radial puncture, where something that can be pressed. So our groins are always protected, and we make sure that our healthcare workers and our doctors in the ER are made aware that they do not puncture the groin of any patient who has been thrombolized, because the last thing we want is to get a huge hematoma in the groin, something that may not be picked up. And after you have done a wonderful plasty, you find that the patient is crashing and he's lost a lot of blood in his groin itself because of hematoma. Logistics is that usually after we've done a thrombolysis or we've done a PCI, patient is of course shifted to the CCO. But for some patients who have been referred from a non-PCI hospital and the patient is stable, we do tend in 24 hours to send them back to a non-PCI hospital. But again, this should be in selected patients after they had a successful PCI. So if the patient is stable after a PCI of 24 hours, we sometimes transfer them back to their parent spoke hospital, sometimes because the patients feel more comfortable to be closer to home, and the relatives also find it easier to be closer to their home rather than traveling all the way to the hub hospital. But of course, this is not for patients who are unstable. Monitoring, again, as I said, length of the CCU stay is usually 24 to 40 hours, but this changes upon the basic thing. So again, this time thing is something that is again stressed again and again, and the time is something that we talked about all our patients, whether they have PCI or they have thrombolysis, all our patients should understand that they should start all this. And again, it's important that not only patients who have had thrombolysis, the other drugs are equally important. So beta blockers, ACE inhibitors, they are an essential drug, important drugs. High dose statins, this is an essential drug along with loading. So along with the loading of aspirin, clopidogrel, we always insist that the patients do get a statin dose in their protocol also. And of course, these drugs are started as early as possible. And of course, they're continued for a longer period of time. Dual antiplatelets, again, the recommendations are the same as the ESC guidelines that we follow. If the patient has had a STEMI and he's got a lytic therapy, we continue the dual antiplatelet at least for a period of 12 months. And if they've had a PCI, either whether they have had a BMS or a DS, it could be 6 months to 12 months of dual antiplatelet based on, again, the bleeding score. If the patient has a high bleeding risk, we may sometimes shorten it to 3 months. If the patient is comfortable and you've done a very complex intervention where your thrombotic rates are high, you could probably continue even longer than that, sometimes even to 3 years or longer. Again, I think I will then sort of skip through this. Again, we also tell our healthcare workers to also risk stratify the 30 days mortality. And this is done by using the TIMI scoring rate. This again gives us an idea to classify patients into a high risk, medium risk, or a low risk. And this is one example where an elderly man, a 65 years old man, who would have a heart rate which is high, a blood pressure which is low, and has an anterior wall MI, and who has a long balloon to door time. This is a patient who has had a high STEMI risk. So this is sometimes important because patients do ask us whether this is a patient is fine or is going to do a high risk. The doctors would say this is not a very high risk, whereas the healthcare worker would say that the patient is in a very high risk, or it may be vice versa. So there may be a sort of confusion among the relatives' mind that one person is saying that the patient is fine and the other is saying that the patient is very critical. So once we have a score that we talk about, it probably puts all of us on the same scale and we talk the same language. Secondary preventions are equally important. And as I said, this is something that our all the medical doctors also help us out with, because sometimes the patients often need to follow up with the consultants, medical consultants, for equal control of diabetes, hypertension, and the other drugs. Dyslipidemia guidelines are also very important for us. For a person who has had a MI, he really falls into the very high risk category where our LDL targets are pretty low. So the Lipid Guideline Association of India now looks at getting an LDL less than 40. And we are very careful to try and get our LDLs as low as possible. And whether that means in giving high intensity statins, whether it means that we give ezetimibe or even PCSK9 inhibitors, which includes Repatha. So we are very careful about reducing the events by giving targeting our LDL cholesterol. But again, as I said earlier, LDL cholesterol sometimes is not so much of an issue in India. It's more of the bad HDL and the high triglyceride, which sometimes become an issue. Rehabilitation is also an important part of our management. And this is again something that we talk about. Many of our patients who wish to travel back to other places, we risk stratify them. You may be in a low risk for commercial air travel. So if they want to travel somewhere back to the other parts of the country, we tell them if they are young patients, if they have had a good LV function, they've not had a planned investigation or intervention with no complications, they're fit to fly within a period of 3 to 5 days. But if the patient is a higher risk, well, we need to tell them not to fly till some period of time. Driving is another thing that patients would ask us whether they're able to get back to their driving. If a patient is not a commercial driver, if he just drives himself, well, usually and if they have no complications with an ejection fraction more than 35%, we still ask them not to drive for 1 month. Driving in India and especially Calcutta can be pretty stressful for many patients, and we ask them not to. The traffic can be pretty stressful. 1 month is what we talk about. If the patient has complications, decompensated heart failure, arrhythmias, then it's probably longer. If the patient is going to be doing a commercial driver, if he's a taxi driver, if he's a bus driver or a truck driver, well, we usually put it over 3 months if he has ejection fraction, and then 3 months later we re-stratify them and see what their diagnosis is. We've always looked at our criteria, and we have an audit which looks at all these parameters that we look at, and it's important that we meet these targets. So all these targets are routinely assessed on a regular basis, and we are trying to assess our outcomes. And this is what our data is, to try to reduce the in-hospital mortality to as low as possible, less than 10%, but we are trying to get it less than 5% to get our 30 days and a 1 year mortality as low as possible. Again, I think we have a unique channel now in the AMI in the COVID era. And I felt this should be something that we could discuss. We all know that MI presents with a varied presentation. There is a varied presentation. We all are aware of myocarditis presenting, patients who have normal coronaries but presenting with ST elevation. There's often a delay in diagnosis and treatment. Patients do not come to the hospital for fear of COVID. Patients who really need treatment are not sometimes turning up. We are not aware of the outcomes. Sometimes in an MI, they have associated COVID. What is going to be the outcome in these patients who have MI along with COVID? Pharmacoinvasive strategy is especially important in the current era, and we are encouraging more and more patients to get thrombolysis done rather than coming for a primary PCI. There are delays in the hospital because of the fact that beds are occupied. We sometimes are not getting our COVID reports, even though we are using the gene expert to get our tests done. We have a cath lab. We have 3 cath labs, and if after the patient has had a procedure and if he is positive, we often need to sterilize the lab and seal off the lab for almost 4 hours and get the re-sterilization done, which often has a bearing on the next procedure that may come in. Again, it's also important to keep our personnel safe and to use our lab resources carefully. And I think personal safety is also very important. All our cath lab personnel, whether it's the technicians or nurses and the doctors, the junior doctors, everyone's safety in this COVID era is equally important. And therefore, when there is a patient with MI, I think these are some of the things that make a decision about how we treat our patients in MI. So this clinical judgment is something that is very important. Any patient who comes with chest pain, well, may not be only an MI. It could be something else. This could be COVID rather than just an MI, and we need to be careful here. We thought we had everything sorted out. We had all thought that we've got everything that we wanted in MI, and just now we thought we had broken through. We realized that there's a big ocean just above it, and we are not yet free. There's a huge, the last 8 months has taught us that we are far away from realizing how best we are in treating, and medical science is still an imperfect science. Thank you so much on this Thursday evening for listening to me. It was a long and probably a boring talk, but I think it's important that we interact and probably learn from each other. And thank you so much for your hearing. And I'm open for questions and any suggestions or discussion that you may have.
Thank you, sir. As usual, extraordinary and brilliant presentation. We are always fond of your presentation. Before discussion, I just introduced Dr. Aftab Khan because everybody known to him, but more than 100 buzzing cardiologists here. I should say a few words regarding Dr. Aftab Khan. Dr. Aftab Khan now is the Senior Interventional Cardiologist and Director of Electrophysiology, Apollo Hospital, Kolkata. Is the faculty of postgraduate cardiology program also. He has 42 publications, indeed medical journal chapters in the 3 textbook. The faculty position national and international conferences, and field of interest coronary, chip cases, more complex cases, electrophysiology. Also is the atrial fibrillation specialist. Thank you, Dr. Aftab Khan. We have some announcement here. This presentation is enlightened our IPDI Cathlab series archive. It was so much excellent presentation. For the fellows, you can go through at midnight every time. Just click the www.hello.health and scroll down, click the IPDI Cathlab manual series, and just subscribe the YouTube channel, and you can enjoy the list. We know this month is our victory month, so IPDI tribute to the martyrs of independence of Bangladesh. We salute those who fought for our victory. Thank you, everybody. I am requesting our co-chairman, Dr. Khaled Mohsin sir here. Dr. Khaled Mohsin sir here.
Yes, yes.
Yes, sir. Yes, sir.
Thank you.
Your comments regarding
Thank
that. Yeah.
Yeah, thank you. It's as usual. We had a very great expectation about the presentation of Dr. Aftab Khan, and we have been very fortunate to be interacting with him a number of times in different conferences as well as in the cath lab. Particularly, he came here as a proctor for CRT cases. So he has lived up to his expectation, and really it is a very fascinating presentation. Particularly in this COVID era, where we are facing a lot of problem in the continuing the primary PCI, and Dr. Aftab Khan has very aptly emphasized upon the pharmacoinvasive PCI, which should be the strategy of this trying times for the patient and the cardiologist as well. So, and regarding the choice of thrombolytic, he has already compared the different thrombolytics and has clearly shown that we should be opting for the plot specific thrombolytic, particularly in the bolus form, though the cost is sometimes prohibitive. And we would like to know about the Indian perspective, whether they are using the clot specific thrombolytic like tenecteplase in greater numbers. In here, it is almost the cost of a stent, the cost of a tenecteplase bolus. So sometimes the patients are not very keen on using it. And in the we have shared the same economic perspectives with India, because the most of the patients have to pay from their own pocket, and it is not a insurance based system. When the patient makes a lot of delay in giving a consent regarding the use of costly thrombolytic as well as going for primary PCI, and sometimes some unfortunate results do occur with the patient having some complications and some litigations. I think our senior cardiologist can make a comment about these things. Professor Mominuজ্জামান sir is here. He can give us a update regarding his experience about this sort of contentious issues. So we need to be very careful about those issues so that we have a good outcome in the initial contact of the patient, and the initial treatment should be given at the earliest available opportunity, and the good result is anticipated. So with this, I like to thank Dr. Aftab Khan again for his brilliant presentation, and thank you, Mohsin, for inviting Dr. Aftab Khan to enlighten us today with his very brilliant lecture. Thank you.
Thank you, Professor Mominuজ্জামান sir. A few comments regarding Khaled Mohsin sir.
Yeah, Aftab Khan, as usual, the great lecture. He actually touched all the sector. I thought that what I will say something about the part. Lastly, he finished that part also, right from the etiology, Indian scenario, Bangladesh scenario, even when to drive the car, everything he touched. And I said that Aftab Khan is a complete cardiologist, both clinical, intervention, and electrophysiology. Very few cardiologists has got this capacity, and really we are proud to have him in this program, and their outstanding lecture on this acute MI. As Dr. Khaled Mohsin said, I think the management of acute myocardial infarction, I'll request Mohsin to make a webinar on these topics, to invite the cardiac society member secretaries, the physicians, the GPs to participate, how we can manage the patient with acute MI right from the grassroots level. What we are seeing in the cities is mostly post-MI maybe 3 hours to 24 hours. So what we do, angioplasty or whatever things, the net result may not be much difference if compared with the treatment if it given within 6 hours or the golden time. And most of the part of the cath lab facilities is based centrally. So not like India, our country is very small. From one part to another part, it will not take more than say 12 hours. So pharmacoinvasive is a good option for tackling the STMI. But what we need the knowledge and awareness of the local GPs, cardiologists, and medias, so that the hurdle remains that once you so, people's expectation is that the patient, whatever the disease, he will come back without any problem. But this is the disease. Even in the best part of the world, the mortality is 10%. So even if you do the best service, so this awareness of the people in combination with the comprehensive approach by the physician, by the GPs and cardiologists can improve. As also we can suggest the government to subsidize the thrombolytic therapy, because if you see the productivities of the young MI patient, after having MI, he will have his heart with a ejection fraction less than 40%. Productivity is gone 50% down. So he will have only heart failure. That is another burden for the society. So I think if we can convince our government to subsidize this thrombolytic therapies like EPI, like anti-tuberculous drugs. This is the drug that is the most life-saving and increase the productivity of the people. These are the issue I think we can discuss in a forum, either by IPDI or by Cardiac Society. Not that the interventionist. It is a comfort effort of all the cardiologists. It is our responsibilities. And we also learned something about uh, Aftab's lecture that they have got the unique database system of the outcome of the procedure. I think this is a lesson for me also, although we are doing it, but not in a very good formative form. So this is one thing I want to learn myself to start these things. And thank you very much once again, Aftab, and thank you all. Even at the 1.5 hour lecture, still participant is 90. Thank you very much, Aftab, and thank you, Mohsin, and all other participants. Thank
Thank
you.
you, sir. Thank you, sir. Here our two internists here, Professor Rohit Amin, Professor Aniruddha Ghosh. They're not only clinician, they are a good researcher, academician. We are everybody known. Dr. Professor Rohit Amin, do you give some comments regarding the lecture?
Oh, thank you very much, Dr. Mohsin.
Yeah.
I first of all like to give thanks to the IPDI as well as to inviting me to become a panelist from the perspective of the general medicine. I will say that it's a fantastic opportunity for me to see the jewels of all the cardiologists sitting all together and discussion and listening very carefully to Aftab Khan's lecture. Absolutely brilliant to see the Mohammad Jamal sir and all sirs in front of us. Thank you very much for inviting me. It was brilliant, absolutely brilliant from Aftab's point of view. I was very much amazed to see the registry that has been shown by him in the Indians. I was wondering whether the equity has been established in the India on the part of this registry or not, because there has been one important consideration.
Please unmute yourself, Dr. Professor Rohit Amin.
Less amount of interest was the global scene. What important things that I came to the lecture is that the maximum delay for the STMI diagnosis to reperfusion is 120 minutes if we consider about the reperfusion technologies, the primary PCI. But what I like to mention in this respect that whether can we delay the primary PCI pathway up to 60 minutes in this time of COVID-19 era or not? Because there was a multiple experience, and very recently there was one establishment of the ESC COVID-19 guideline or guidance, I would say. They said that the delivery of care in this COVID-19 era maybe some delay happens due to some protective measures occurs in every section of the healthcare provider. So this is an important consideration. Second, another point that I like to mention about the non-culprit lesion, what he has been saying is absolutely correct. In this COVID-19 era, the non-culprit lesion with clinical stability as well as the angiographic blood vessels measurement is very crucial. And I like to know from Dr. Aftab Khan whether if somebody is symptomatic, evidence of ischemia is there, if the lesion is subocclusive, and if it is angiographically unstable non-culprit lesion, shall we do the PCI during the same procedure or hospitalization or not? Because if you do it in a staged way, then in this COVID-19 era, I think there's a big possibility that transmission can be a big trouble. But it was a fantastic, I would say that the primary care by means of ambulance through is less in our country. Here, people are actually come on their own, and sometimes 24/7 the hospital facility will not be available. So they will have to transfer from another hospital. And whether the 120-minute that has been established, said by your son, is possibly not happening routinely in our country. But we came to know a lot of things from Aftab Khan's lectures from the top to bottom. And I really appreciate this continuation of his lectures to be continued by the IPD. And we'll be delighted the internet to come forward to listen to him. And also our legendary professors regarding the many issues of the cardiac. Thank you very much for inviting me.
Thank you. Thank you. Dr. Aftab Khan, do you hear me?
Yeah, I can hear you, sir.
Yeah, for the complete device scanning in case of primary PCI.
Right. Yeah. So I think I was just listening to Professor Amin, and I think he put two very important points. As he said that the guidelines have now spoken of a delay of 60 minutes that is permissible now. And yes, initially, as we said that we had initially thought that we would be doing thrombolysis for all and not taking these patients to the cath lab because of the fact that earlier, even the testing methods, the RT-PCR used to take 24 hours. And we really did not have the gene expert method, which would give us a result within 2 to 3 hours. So when we did not have these methods, and really the initial 4 to 5 months of the lockdown after March, we really had sort of come down on our primary PCI rates. But now, as the fact that, as I said, because it's not only the patient, it's important that we protect our healthcare workers also. If you keep on getting your cath lab technicians and your nurses infected, then probably you'll have no one to sort of help you out in your cath lab also. So therefore, it was important that we take equal protection of our co-workers also. And that is why it was important that even a delay of 60 minutes in the guidelines, the European and the ACC guidelines have talked about a delay that is permissible. The Indian Cardiology Society of India has also released guidelines, but this was in the early part of the COVID era, where again, similar to what we have been doing, they have stressed more on thrombolysis rather than primary PCI or a facilitated or a pharmacoinvasive approach rather than taking patients into the cath lab. But that point is well taken, Professor Amin, and I think we do accept a little bit of delay, but I think we always look at what is safest for the patient and for the healthcare worker. The second point, compared to the non-culprit artery, I think it's the same whether it was in the COVID or the non-COVID era. If the patient, you've done a culprit artery and you find that the patient is still unstable. So for example, in an anterior wall MI or in an inferior wall MI, sometimes you have a circumflex lesion and you also have an RCA lesion. And we know that both the circumflex and RCA can produce changes in the inferior leads. So sometimes it becomes difficult to know which of them is the culprit. And we'll go by what is most thrombotically visible or which is more occluded. So in a patient with an inferior wall infarct, you probably may do the RCA, but you then find that the patient is still having chest pain despite a good flow in the right coronary artery, or you find that the hemodynamics are not improving and you have a critical lesion in the circumflex. You could probably say that because the patient is not stabilizing, you could probably do the circumflexplasty also in the same go. But if the patient stabilizes after the RCA plasty and it still has a critical lesion in the RCA, we would probably wait on and then get the patient after a period of 1 or 2 days and then get them to the lab rather than probably doing it at the same stage. So that was the approach that we follow. But again, I think each patient is different, and I do trust that the primary operator would be the best person to assess what is comfortable with.
Thank you, sir. I introduce Professor Aniruddha Ghosh. Professor Aniruddha Ghosh, do you hear me? He's the Professor of Medicine of Chittagong Medical College Hospital. Professor Aniruddha is the expert of snake research in Bangladesh. He produced the antivenom in Chittagong in for Bangladesh perspective. Professor Aniruddha Ghosh, please, do you hear me? Please unmute yourself.
Yeah, I hear you.
Yeah, please comment regarding that. topics. Yeah.
Okay, first I must congratulate Dr. Aftab Khan for his brilliant presentation. And it was a varieties of information for me. We are just internists looking after everything, not doing much thing. Anyway, and I feel grateful that I don't have to remember all those stages and others. But the way he presented this is very useful for me. Hats off to you. But I, regarding this, while I was listening to him, I had some question that usually it is said that when you suspect of an myocardial infarction, get the patient some aspirin or clopidogrel. Which one? Is it aspirin? Is it clopidogrel, or is it combination? I would like to have a clear guideline about that, because I have gone to several and they have made it according several guidelines from different countries. They have made it according to their what that suits in that country. Because if I say that you give that patient some Plasugrel or others, you won't find it in any upajelas in Bangladesh. Aspirin is available, clopidogrel is available. I would like our professors, eminent professors of cardiology in Bangladesh, to come up with a guideline. Next is low LDL. He said that as low, so far, as low as possible. When I say as low as possible, my neurologist colleagues, they say that if you lower it below 70, there is a chance of having intracranial hemorrhage. So what should we do? Third is, when he presented the epidemiological study registry, mainly the registry, that I find that apart from every other states in India, Kerala is doing something extraordinary. We should, or they should find out what is the main reason. Is it only the literacy? Sri Lanka has more than 95% literacy. Many other Western world have other higher literacies. Is it only the literacy? Just my question. Because similar thing happens with snakebite in Chittagong. The rate of patients presenting directly to hospital in Chittagong is much higher than any other part of the Bangladesh. Because we are doing the public awareness, running a clinic and others. I'm just citing an example from my own field. Third is the registry. I'm not sure whether we have a registry, because this disease is now, sort of epidemic, the coronary artery disease and others. The cardiologists, the societies of cardiologists should think about doing a registry. The way Professor Dr. Aftab Khan presented the registries in India and others, I feel ashamed. I'm not sure whether we have this thing or not. If not, then we should have it. Another thing is that during the can you hear me, please?
Yes.
During this epidemic, we are having some patients with COVID deteriorating suddenly. Not, we suspect that this is a cardiac event, but we cannot prove that. When we are talking about type 2 myocardial infarction, there is a suggestion that there is a possibility of type 2 myocardial infarction during the COVID. We need some guidance from you people, our cardiologist colleagues, that what to do or what not to do during that time. Third is that the topics just discussed, the delay, whether we can increase the timeline for another 30 or 60 minutes. When that timeline was set, that was a non-COVID area and others. That was purely on scientific basis that during this timeline, it is the most beneficial to do this PCI or other things. COVID put us in a difficult situation. Before extending that timeline, I would request to rethink by that, because due to COVID, there will be delay in testing and others, there will be other, but whether this is going to be scientifically sound or scientifically safe for the patient. Just delaying the timeline for another 30 minutes or 60 minutes during COVID, whether this is going to do us any good.
Dr. Khan?
Just one more minute. I would request Dr. Mohsin to give us another SOP for those doctors in our medicine wards when they are suspecting a MI in a patient admitted in medicine ward. They suspect, they do an ECG. If there is something, then they send this patient. If there is nothing, they send for troponin I and others, but there is no consensus or there is no guideline. Yes. I request you people to formulate a guideline or an SOP to be used by by my doctors in medicine ward when you suspect or you confirm an MI, do these things, and they will follow that, because it takes sometimes it takes more than 30 minutes to reach from one ward to another ward in CMCH. This is not acceptable, we know.
Exactly.
But this is real-time scenario, but for that, to overcome that and to make the most of the beneficial, make it to put the most benefit to the patient, you put us a guideline or SOP that just do these things, put this give this drug to the patient, prepare him like that, and then send him to CCU. Thank you for listening. I am very thankful to Hello and the organizer of this group to invite me to be here and to speak. Thank you very much.
Thank you. Dr. Aftab Khan, do you hear me?
Yeah.
Dr.
Ghosh had a lot of questions, which unfortunately there are certain things I may be able to answer. There are certain things that I think we are all still learning. Yeah. And I can just share some of my experiences and how we can help you to build up your registries and other things. So coming to the medical part first, as Professor Ghosh has asked about the loading dose, I think we still also, as I said very correctly, once a diagnosis of chest pain is made and the symptoms is very classical, the patients are told to take aspirin 300 milligrams immediately. Now, the second antiplatelet would be only after an ECG, where we then give them clopidogrel in majority of the cases. As Professor Ghosh also said, ticagrelor and prasugrel may not be available in many of the peripheral centers, and clopidogrel still remains the preferred choice. Now, the dose of clopidogrel would be based on the therapy that we're getting. If the patient is getting a thrombolytic therapy, the guidelines talk about giving 300 milligram loading dose. Whereas if the patient is going for a primary angioplasty, then the guidelines talk about giving 600 milligram loading dose. So the loading dose of clopidogrel is based upon whether the patient goes to the cath lab directly or he's getting a thrombolysis and getting a pharmacoinvasive approach. And then the follow-up dose is 75 milligrams daily. So it's either 300 milligrams or 600 milligrams based on whether the patient is going for a primary angioplasty or the patient is getting a thrombolytic therapy. So I think that hopefully will answer the first question. The second question is about, I think he talked about the epidemiology and the other registries. And again, I think, believe me, this is something, so this is something that we are seeing here, and this is not something that we have done over a year time or over 2 years time. Believe me, this is a work of almost 20 years, and still today we are struggling to get our patients to understand the importance of their chest pain and to understand that this is everything that is in the chest is not gas. So that is what is important for us. Registries help in two ways. It helps you to identify your own data to say whether you're doing better or you're doing worse. So that is one thing. And second thing, as Professor Momin Zaman was saying, that it often helps you to get your healthcare, the persons who are in charge of decision-making policies, your policy makers, the ministers and the politicians. When you show them data, that helps more rather than telling them that this is what it is. So if you just tell them that we want to have patients who are dying of MI of this many, they may not understand so much unless you have a registry of many hospitals. And I'm sure with the wonderful believe me, this is really genuinely from my heart. I've seen many of you have interacted with many of you, and you people are doing phenomenal work in terms of patient care. And if you can just pool your data together, it does not have to be one center. If you all pool your data together, you will have a wonderful data to know what exactly is being done. So these are simple things, and I don't think so this is a very difficult thing. And this is something that has to be started prospectively. We don't do any just collection of data, which is there in the lab, and you just have to pool together your data to get a registry. Sir also talked about Kerala model. See, the Kerala model is something that we have been only able to partially understand. Definitely literacy plays a great role, but sometimes literacy also has to be coming with acceptance of therapy. If you are very literate and you would start, your literacy translates into going to a Google and making to diagnose what it is, or if you are literate enough and you think you know more than the doctor, then your literacy may not translate into good outcomes. So that's what happens. We also in our part of the country, again, without being sort of judgmental about anyone, we also have a lot of literate people in the eastern part of India, in Calcutta and other places. But unfortunately, their literacy translates into taking too many opinions or trying to take a decision for themselves, not trusting the doctors, which sometimes does not translate into good outcomes. Whereas the literacy in Kerala probably translates into people understanding that the doctor there is trying to do good for them, and that may be a reason. The government has done great in terms of helping us out with therapies. So as Professor Mohammad Zaman was saying, that getting the government to help you in terms of reducing the costs. So we have now insurance systems that are given from the government aided. And this makes primary PCI, even in government hospitals, very easy. And even in peripheral hospitals to receive thrombolysis with clot-specific or fibrin-specific thrombolytics much easier. The question again of the thrombolysis with angioplasty, as I said earlier, many of our young patients, and I think this may be the thing that you might have found also, even if they receive streptokinase or they receive any thrombolysis, many of these young MIs, they come with clean arteries. And if you do an angiogram later on, you find that there's no blockage at all. So thrombolysis sometimes can help you to get the artery open completely. There was another question in the chat box there where they wanted to understand what's the earliest time for angiography after streptokinase. So there were two approaches. One was known as the facilitated angioplasty, and the second was pharmacoinvasive angioplasty. So in the facilitated angioplasty, what was done is that patients were giving half dose of thrombolysis. So they were given half dose of thrombolytic agent, whether it is streptokinase or tenecteplase, or even a GP2B3, and they were shifted to the cath lab immediately. And within a period of 1 or 2 hours, patients had to undergo an angiography and an angioplasty. The facilitated angioplasty group, where it was seen, where you give half dose of thrombolytics and then took the patients up immediately, well, it was found that angioplasty group had a worse outcome as compared to the thrombolysis group. And the results that were anticipated were because of the fact that it was thought that post-thrombolysis, there is a prothrombotic state. So when you do an angioplasty and put a stent there, there is a prothrombotic state that is ongoing. Plus the fact that because you have given half dose of thrombolytic, there's sometimes this plaque hemorrhage also. So you may have put a stent, but there is hemorrhage inside the plaque. And this may contribute to more stent thrombosis and more events. So this facilitated angioplasty, giving half dose thrombolytic and then shifting the patient for an angioplasty very early, was then discarded worldwide. And now what is more appropriate is pharmacoinvasive therapy, where you give streptokinase or you give tenecteplase or you give the retiplase, the full dose of it. And then it's only after 3 hours to 24 hours. So the initial intention is not before earlier than 3 hours. It's only after 3 hours that you take these patients into the cath lab and then do a procedure anywhere between 3 hours to 24 hours. And this is found to be much better as compared to facilitated angioplasty, where they took them very early after giving a half dose of thrombolysis. Again, I'm sorry, I've forgotten many of the questions that Professor Ghosh asked.
You touch every person. We are lucky enough, Professor Rahman, our teacher, our leader also, he also works in the Ministry of Health, Minister also, Healthcare Government. So, Madam, please guideline for till now, we not prepare our guideline for the STMI management in the Upazila Health Complex. Also, Dr. Ghosh also said, Professor Ghosh, in the medicine ward also. Regarding this opinion, Subhay Madam, you give some opinion. Madam, you hear me?
Yes.
Yeah. Yes.
Assalamualaikum. Good evening. And Thanks for, I joined a bit late. Nice to see Aftab. It's a long time ago when he visited first time in Bangladesh, and we did some work with him. And his presentation was absolutely nice. And in this long time, he did present very nicely. There are a lot of things one can discover. He has touched everything. And if you talk about Upojala, what in our time it was only aspirin, then nothing else, and then it came the thrombolysis, and now you have got a lot of antiplatelets, different type, which one cannot tolerate, the other one can be used. If one is not acting, the other one can be used, like that. And also thrombolysis is different type of thrombolysis is also available. Since they're in the Upojala, there is no cath lab, and what they can do, the first thing is stabilize the patient, first diagnosis, and if you confirm about the diagnosis, then you give what is the immediately needed, that is in terms of aspirin, clopidogrel, and then thrombolysis. They can do it in the hospitals, and then you cannot do the primary in that situation. But if fortunately if there is any hospital there very nearby where they can go in 10 to 15 minutes, so they are very lucky people, and they can go to the place where there is a intervention is available. Other than that, they have to manage like that. One should, when treat the acute MI, should be aware of that they can land up in any problem like arrhythmia, land up in left ventricular failure, land up in thromboembolic phenomenon. So all these, if the one knows, they can always deal with it, and that should be in their mind, how to manage. And I think to talk about that, you can have one a day for the general practitioners what to do, and the people in the Upojala what they can do for this patient. If you have if we can give them some guideline, surely our patient will be benefited, and our physicians will be able to treat them properly and peacefully. I did have one question. Can I ask, Aftab?
Yeah, it will be an honor, ma'am. I'll try and answer if possible.
How are you, sir? Okay.
I'm fine. Thank you so much, ma'am.
Okay.
It was an honor
I
being
just want
here.
to know, in this COVID era, when you are using all these antiplatelets and all sorts of nice fancy ones available. I'm glad these are available now. In our time, it was not there. Patient have not they having angina, and then the past history of bypass, angioplasty, etc. was done. Diabetic patient, hypertensive patient, dyslipidemic patient, octogenarian, and these patients having in this COVID era have COVID pneumonia and then recovered. And these patients, can we add the rivaroxaban in that patient, in what dose? Because they are octogenarian. And what is your experience about that?
Right, ma'am. Ma'am, it's such a practical question that we're seeing nowadays, because I think, though I'm not directly involved with the COVID treatment and we have a separate COVID team, but we do usually get called for many of these patients. So as a protocol in a hospital, in addition to the other anti sort of COVID measures that patients are being put into, one of the common things that they do is to put these patients on heparin. So all patients in the hospitalized state would receive some form of low molecular heparin whilst they are in the hospital. And once they are shifted out and they're more ambulant, many of these patients, irrespective of the D-dimer status, because we know that COVID is
that is high. I'm really talking about a practical patient. I had a few days ago. I have done it, but I just want to know what you people are doing. So D-dimer was more,
Right. So they, irrespective of the D-dimer,
hemoglobin was low.
Right.
And the patient had heart failure controlled, but when he went home and he has started having again heart failure.
Right. So these patients are definitely put on some form of direct oral anticoagulant. So rather than warfarin, these patients are usually put on one of the novel oral anticoagulants. And most of the time it is the rivaroxaban that's being given in our hospital. So our hospital
10 milligram or 2.5 milligram, which one you do? Because of the age, I'm talking with 65 low, I don't have any tension.
Right.
This is octogenarian patient.
Yes. So again, I think it will also be based on the clinical profile. The problem with the rivaroxaban is that in many of the trials, especially the ROCKET-AF trial, it has shown that there is a higher incidence of GI bleeds with rivaroxaban. So in this patient, if you have an unknown diagnosis of anemia, which you're not certain about, probably apixaban is something that we'd prefer in this group of patients rather than giving rivaroxaban, because there's a higher incidence of GI bleed that has been noted with rivaroxaban. So in this group, probably if you, as you said, he is elderly. If he's elderly and if he has a creatinine clearance which is less than 30 ml per minute, then probably it will be 2.5 milligrams of apixaban that we'll probably put twice a day in this patient. So, so the group, I mean, the choice of this, definitely rivaroxaban is beneficial because it's an OD dose as compared to the others, which are a twice daily dose. But again, I think sometimes we look at the clinical situation and then take a decision. So in a patient with unknown bleed or unknown anemia, non-diagnosed anemia, probably we would be more comfortable with apixaban rather than rivaroxaban.
Thank you, Abdul Khan. Yeah. Madam, do you anything or?
Thank you. Yeah, is there anything else I can do? I can.
Thank you. Dr. Samsonwar, sir. Dr. Samsonwar, you hear me, sir?
I can hear you. Thank you. Yes, thank you very much. I was actually, Dr. Aftab Khan, thank you very much for the brilliant presentation. I was actually listening to all the discussions, and you at the end you said it's a boring lecture. It's not boring actually. It's very interesting, and you can see the number of participants is how important this is.
No, sir. I think for us sometimes it is. I mean, because we've been, since we are interventional cardiologists, many times people expect us to show a lot of cases of angioplasty, and people find that when we talk about medical management, they say, "Oh, this guy is coming and talking about things that we already know." So that was the reason that sometimes it is very difficult to know the audience. And when I'm speaking in front of legendary cardiologists like all of you, so I did not really know what to show and what not to show. So I said it's better to go back to the basics and just learn from you all and discuss what we are doing and what you are doing, to learn and understand the challenges that all of us have. And as I said, I've seen the work of all you legendaries, and believe me, you people are doing a phenomenal amount of work in terms of intervention, and something that you should all be very proud about in terms of what you've achieved at this day.
Thank you. I have a practical today question for you, problem for you, not question. In this COVID era, actually for the MIs, we are, as you suggested, we are doing the facilitated things with the 10K place. But suppose, hypothetically, if a patient comes in a cardiac shock, anti-MI cardiac shock, young patient, coming within an hour or two, a patient has no blood pressure. I mean, ideally, should have gone for primary PCI. But in this era, what will be your approach?
Yeah, so I think there was a question that was asked by Professor Ghosh also when he asked about these patients who have an MI and they find that they have nothing in the coronaries. So I think we have realized that COVID has played a lot of distort with the ECGs that we see now. And many of the patients, I mean, we have many case reports that have been reported from many of the places also. And we have seen one or two cases where we've had flank-blown ECG changes, which are with regional sort of changes suggestive of an MI. And we've taken these patients into the cath lab and we found that these are normal coronaries. So there's an entity which has been well described, which is known as MINOCA. MINOCA is myocardial infarction with non-obstructive coronary arteries. So the guidelines have also talked about this MINOCA, or myocardial infarction with non-obstructive coronary arteries. And they have said that you should do an angiography to decide this. So there are two things. When you have a patient who has got an MI and he has COVID, there could be two options: that we thrombolize these patients on a basis of a suspicion, or you take them into the cath lab. So we have realized that probably just thrombolizing these patients, as we have said earlier, well, many of these do get away, but we are a little concerned about bleeds in this group of patients also. And there's a patient who has cardiogenic shock. I would definitely say that we would still take this patient to the cath lab and do an angiogram. Well, as I said, we are also aware that these patients could have probably normal coronaries, could have myocarditis as a presentation for his poor LV function and his low cardiac output state. But then in these patients, definitely I would still give him the benefit of the doubt, take him into the cath lab. Well, of course, making sure that we have the full PPEs and everyone is taking adequate protections, and then taking these patients in. Because thrombolizing in this group of patients, even if it's a obstructive disease or a non-obstructive disease, may sometimes do more harm than benefit. So thrombolysis in cardiogenic shock, probably we all know, has not great data. And I would probably take this patient to the cath lab, sir, and do the procedure. Of course, I think there's one more question in the chat box about the use of and as Madam was also saying, Madam Rahman was saying, how do you use the antiplatelets in this era with COVID infection? And believe me, that's a tough question to answer, because I think our COVID specialists are all interested in the anticoagulant part of it. And we as cardiologists are more worried about the antiplatelet part of it. And sometimes we have to find a middle way. And the guidelines of anticoagulation in atrial fibrillation, those are ones that we normally keep in handy. And when we have a triple antiplatelet, when you use aspirin, clopidogrel, and a DOAC, then we are a little concerned about the bleeds. So the first thing that we do is that we try and get the aspirin out as early as possible, which could be as early as, say, 3 days, or pre-discharge, as early as 3 days to 7 days. We give aspirin, clopidogrel, and a DOAC for the first week. And then we get the aspirin out as early as possible and continue the clopidogrel or the P2Y2 inhibitor and the DOAC for a period of 3 months. And then 3 months later, we make a reassessment and see whether the thrombotic rate is higher or the bleeding risks are higher. If you find that the bleeding risks is higher, and we use the precise ADAPT score, so we have these scoring systems that you can do on your mobile app also. So if you find that there's a higher bleeding risk, then we get off the clopidogrel and continue with DOAC alone. But if you find that there's a higher thrombotic risk, so if you've done a complex left-hand procedure, you put multiple stents, long stents, and the risk of thrombosis is higher, then probably we would continue the DOAC along with clopidogrel for a longer period of time, and then get off the clopidogrel at a later stage. So this is something that we were following even in the COVID era, especially because of, as Dr. Rahman said, Madam said, that anticoagulants is definitely becoming an important drug also in these patients. And sometimes you may have to take care of both the anticoagulant as well as the antiplatelets, and it does become sometimes a challenge in this group. So.
Thank you. I again come back to our faculty. Before coming to the faculty, two of my participants, foreign participants here. Dr. Sanjita Ansari, do you hear me?
Yes, sir. I can hear you, sir.
Yeah. Put your question. Yeah.
Thank you, sir, for giving me the opportunity to ask a question. So it was a very excellent and elaborative presentation. I have 2 questions for you. The first question has already answered. The question was complete revascularization in non-infarct-related artery.
Already answered.
Already answered. The second question is, sir, what will be the time frame for the viability assessment in the STEMI patient presenting after 24 hours?
Yeah,
nice
wonderful.
Question.
I think, Dr. Ansari, I think that those are very, very practical questions. And these are challenges that we face always. As I said, well, it's good to be having these guidelines which guide us. But I think the real world scenarios is that many times these patients do come pretty late, and we see them 24 hours later where they have not received any form of treatment. Forget thrombolysis or class C, not even thrombolysis. So the guidelines are very clear. For example, if you have received a thrombolytic therapy, and this is what thrombolytic therapy often does, especially alteplase and tenecteplase, is that it opens up the arteries enough to restore blood flow. So your stenosis may still persist, but your flows to the distal myocardium is often restored. And these patients have a myocardium that is probably living, but maybe ischemic. So if you see a patient 24 hours later and you do an angiography and you find that there is TIMI flow that has been established, and if you see that on non-clinical assessment, for example, looking at ECG, you find that your ECG is still showing some preserved R waves, or if you do an echo and you find that you still have wall thickness that is preserved, even though the wall may be akinetic, but it has preserved wall thickness, then if there is a preserved flow, we can still go ahead and do an angioplasty for this artery, because you have restored the blood flow earlier, and therefore the chances that the myocardium may receive its viability again is much greater. So this is a 2B recommendation from the guidelines. But if you do an angiography 24 hours later and you find that the artery is completely occluded, and if the patient is stable in terms of no chest pain, no electrical imbalance, and if you see that the R waves are completely knocked off, they're complete Q waves on the leads that we're looking at, well, then in this patient, doing an immediate angioplasty may not have much benefit. So in these patients, then we do an assessment in terms of a viability. Now, again, coming to the timing of the viability assessment, I think it's something that is not really mentioned clearly in the guidelines. So we don't rush to do a viability assessment on day 2 itself, because many of these patients, when they have lost a lot of their myocardium, they may be not stable in terms of heart failure. They may be in incipient heart failure. They may not be able to lie down flat. They may have other problems also. So we make sure that we give the optimal medical management first. And then once you've already lost the time of 24 hours and the myocardium is already dead, then probably the urgency may not be there. But it's usually after a period of within a period of 48 hours to 72 hours that we make sure that we do some form of assessment And in most of the cases, it's a myocardial perfusion imaging to help us to identify whether there is a viability. If you are lucky enough and you have the facilities also, you could also do an FDG PET to know whether there is a glucose uptake to understand whether there is a viability. But sometimes the myocardial perfusion imaging itself is good enough for us to identify that. But in terms of guidelines, it's very difficult to identify, but usually 72 hours is what we normally tend to look at after a 24-hour period has already passed in a stable patient, of course. Yeah.
Thank you, sir. Dr. Subhash, do you hear me? Dr. Subhash? Dr. Subhash Sapkota? Dr. Subhash? Dr. Aziz Rahman? Dr. Aziz Rahman?
Thank you, sir, for your brilliant presentation.
Yeah.
Sir, my question is, most of the people in our country, also in this subcontinent, present lately after 24 hours. And what's the further management of this group of patient? Post-MI patient after 24 hours or 2 days, 3 days later patient present with us. What is the management plan in this group is a vital group because most of the people do not get a hospital in time. We just only discharge the patient with advice, but what is the actual plan for this group of people, for the patient?
All right. So I think again, Dr. Rahman, that's a very, very practical question that we see in many of our patients also. And this is the real ground reality that many of the patients do not receive not even aspirin before they come to us after 24 hours. So there are two things. We look at two things. One is initiation of the optimal medical management, which would mean that these patients need to be on aspirin, they need to be on clopidogrel, and they need to receive some form of heparin. In most of the times, the heparin that we give them is low molecular heparin. And this low molecular heparin is continued at least for a period of 8 days. So the upper limit is usually kept at 8 days, but at least while the time that the patient is in the hospital, they would receive some form of low molecular heparin. And of course, they would receive the other drugs, which would include high dose statins, and it would include the other beta blockers and ACE inhibitors and MRAs, and of course, the optimal medical management that you can give for these patients. When again, as I said, as Dr. Sanjita also asked earlier, we need to then risk stratify these patients to identify what exactly we do with them. If at all there is a viability that is noted, then these patients should go early to the cath lab and get their arteries revascularized. If the patients already have a myocardium that is already dead, then I think we just leave them on optimal medical management and then reassess them 6 weeks down the line. So the reason for reassessment 6 weeks down the line is that we have give them the best medical management, and this best medical management also includes the use of ARNI. So I think we have enough guidelines now to say that we replace our ACE inhibitors with ARNI now, so angiotensin receptor neprilysin inhibitors now, because they have been shown to have mortality benefits over and above the use of ACE inhibitors or ARBs. So we switch them to ARNIs. We look at their beta blocker usages, try and give them the maximum beta blocker that they can tolerate, give them the mineralocorticoid receptor antagonists, the eplerenone or the aldactone to get their mortality benefits, and of course give them statins and their antiplatelets. And then 6 weeks down the line, we reassess the LV function. There is an indication for a patient who has an LV function less than 35%, 6 weeks down the line after an MI. If you have an LV function still less than 35%, well, these patients are at high risk of arrhythmic deaths. And therefore, we need to reassess them, probably speak to them, though this is a second primary prevention therapy. So this is a primary prevention indication. You must get a Holter done, find out if it has other risk factors. And of course, as I said, our medical colleagues also help us out with a good diabetic control of their hypertension and control of dyslipidemia. And again, coming back to the question that I think the professor also asked again, this fear about the LDL reduction, I think we also had this fear, but there have been two major trials with the PCSK9 inhibitors. So the two trials are, one is the 4-year trial and the other one is the Odysseus trial. So the 4-year trial was done with evolocumab and the Odysseus trial was done with alacumab. So both these trials have had more than 25,000 patients each in the arms. 2,000 plus patients in the arms, and they have had a follow-up period of more than 2 years, and their LDL cholesterols used to be less than 30, and none of these trials have shown any significant neurocognitive effects. So this risk of bleed that we had always anticipated and thought of has not been found to be true with the large trials that have been done. And therefore, this getting the LDL down is something that we aggressively follow. And as I said, we look at it 6 weeks down the line, and then take a reassessment of whether we want to angio these patients, or I mean, not 6 weeks down the line, we take a reassessment and then decide whether the medical management needs to be optimized. And again, now we have more drugs. Now we also have dapagliflozin, which has now shown to be beneficial in heart failure with reduced EF and mortality prevention also. So I think we use the best medical management that is now available. And we also look at arrhythmic death as one of the reasons and counsel the patients if they are financially capable to undergo an ICD implantation.
Thank you, sir. Dr. Choyan Singha, do you hear me? Dr. Choyan, please put your question, just brief question. We are passing 2 hours more time. Dr. Choyan Singha.
Sir, I have one question. In acute coronary syndrome, which statin should be used first? Either atorvastatin or rosuvastatin. Is there any choice difference?
Again, I think, yeah, Dr. Sinha, that's a very, very practical question. Again, I think there is no head-to-head trial to tell us which statins is good. What we know for sure is that it has to be high-intensity statins. So we don't really need to look at lipid profile. We can send a lipid profile, a non-fasting lipid profile later on, but patients have to be on high-intensity statins. And high-intensity statins means 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. So I think it's important that we realize that the initial benefit of all these statins is more for its pleiotropic effects, for the fact that they have anti-inflammatory effects, they have anti-thrombotic effects, and these are more important rather than the LDL lowering. So the first few weeks that we see the benefits of statins, of the high-intensity statins, it's more to do with the pleiotropic effect rather than the lipid lowering effect, because you don't really get lipid lowering within 1 or 2 days with statins, but something that you can see with the PCSK9. So there have been 2 trials, the EVOPAC and the EVAX trial, which has looked at PCSK9 inhibitors in acute myocardial infarctions. And they have shown that the LDL levels drop as early as 7 days after the use of this PCSK9. But again, these are not in the guidelines as yet, and one has to use it based on the cost of the PCSK9 for the more high-risk groups.
Thank you, sir.
Thank you, sir.
I introduced Dr. Arifur Rahman Shajol. Dr. Aftab, do you hear, know him?
Yes,
Dr. Rahman?
Yes, yes, of course.
He's a workhorse of IPDI.
Yes.
But he's the most important, he's the working 24/7 in COVID era primary PCI. At midnight doing the primary PCI in the clinics. Yeah, Dr. Arif and also Dr. Selim, Dr. Mahub, elaborate. Dr. Arif, do you share your experience, the COVID era in primary PCI? And just quickly read down the chat box question for the Aftab Khan. Yeah, Dr. Arif.
Hello. Yeah. Hello, sir. Assalamu alaikum. I have been a great fan of it for long. We have lots of questions, practical questions. And one question is, in real world, most of the time we have observed we fail to follow the guidelines, especially the time limit. Suppose one patient came to the emergency and there is a call for the primary PCI, and it has been observed we are preparing the patient from emergency to CCU to Cathlab or emergency to Cathlab and preparing the Cathlab or in the serial, we miss the timeline. In that case, what is the actual what real world management in this situation, whether we should proceed or we go for the guideline directed thrombolysis like this?
Right. So I think that's a wonderful question again, Dr. Ariful. And this is something that is very practical. And I think what we look upon any patient who comes to the emergency or any patients with MI, I think we do what we call as the grandmother test. So if it was one of my grandmother, how would I treat this patient? I think that's very important when you treat any patient. And I think our important thing is that we always make sure that we try and stick to the time limits that have been set. It may not be always practical or possible because there's someone who's one of your labs is being taken by one of your colleagues who's doing a complex procedure, and the other lab is probably in the COVID era, it's under being sterilized. So these problems are pretty practical, and it's important that we then think about what best we do. So I think we've lost some patients when we just kept on waiting in the emergency, and we've seen these patients go down because the relatives are waiting for us to take them to the cath lab. We have counseled them about the time factor and the fact that time is muscle and everything has been done. And then we are just sitting there trying to shift the patient, but the patient lab is not ready. And then we have lost patients, and it made us very, very sad that we've sort of not done anything for this patient. So in this case, what we do is that if you find for some reason that our door to balloon time is going to be more than 90 minutes for any reason, which is logistic, not really medical, then we have moved on to the pharmacoinvasive approach, and we have thrombolized this patient in the emergency. Because what we do by thrombolysis is that we at least restore blood flow, which by primary PCI, the main intention that we have intended for, if we keep on delaying, you have lost the muscle and you've probably lost given the benefit to the patient. So I think that's important to ask for it, for us to realize. So we have this option. We can always thrombolize the patient and then get them later on after the after say 3 hours after the thrombolysis, and then do the
Arif, last question. Yeah.
Sir.
Yeah.
Sir, another question is also a practical situation. I'm experiencing a case. A patient presented with extensive anterior MI and as angiogram showed LED total operated from the proximal part, and we fixed the lesion and patient shifted to CCU. The next day, patient again in a complaint of severe chest pain. We do the echo, we did ECG, and still the chest pain was continuing. Then again, took the patient to Cathlab, and we found the LED stand is okay. There is no stent thrombosis. And the thing is that he has got also a significant RCA lesion around 90%. So we discussed with our other colleagues of the department, and we decided to go for the RCA stenting. And after doing that, the pain relieved, and patient ultimately discharged with good condition. So what is the experience in this situation, or what do you suggest regarding this type of lesion?
All right. So Dr. Ariful, I think this is what we were just discussing earlier, that sometimes when you have two lesions, it may sometimes be difficult for us to understand which is the culprit. And many times we may have an LED, for example, which is a chronic occlusion, and the RCA may be the more culprit. I mean, of course, I trust your clinical judgment and your ECG findings, and I'm sure that the LED must have been the culprit. But this is such a patient. For example, if you've done the LED and the artery has been restored good, and the patient is still not comfortable, the patient is still having chest pain, you'd probably take this patient into the cath lab just like you did and do the other artery. So we would not send this patient home and do a staging in a week's time. We probably would do it a staging in the same index in the hospitalization period also. May not be in the same setting, but probably the next day or the day before discharge. So this is exactly, I think, a decision that has been left onto the clinical experience. And some lesions may be pretty simple forward. There may be an 80% lesions, which is very simple, where you're comfortable to understand that you're not going to cause dissection, you're not going to cause a slow flow. The guidelines therefore have moved from class 3, where it was absolutely contraindicated to touch a non-culprit artery, to class 2B, where if an operator feels that it is comfortable, he may go and do a procedure also at the same time. So you also have data on your side. Even if you are doing the RC on the same go, you may not be wrong. But again, I think it's a clinical judgment, and it's best that the judgment is taken. If you're going to use a lot of contrast, then again, it's better that you stage the procedure on the next day rather than doing it in the same setting.
Thank you, Arif.
Thank you.
Mohsin,
yeah, madam.
No, yeah, Arifur Rahman, what you are saying, this thing happened to me quite a few times. It happened, and we did that. And then we found that the patient is stable for a few hours, and the early morning it started pain again. And so much pain that you give pain reliever and you give nitrate, all this, nothing is doing, no ECG change. But the idea was first to do that according to the ECG, you have treated the culprit lesion. But if there is a duo, triple or double vessel disease, they are culprit or seriously stenosed, then you did the right thing to do it again to see whether there is anything wrong with your implantation of this stent. And if not, then you look for the others, and which you did very rightly. And that should be the protocol to do it. They are all your protocol, all your guideline fails because your patient is first. So you take the patient and you see whether there is anything, and you've rightly found that there is another lesion, which we have also found. And then you treat that, then the patient is suddenly nice and cool and no complaint of pain. And then you wonder, why didn't I see it before? But that time it was not your fault at all, because you treated rightly, the right time, the culprit lesion. But there was also double vessel disease or triple vessel disease. It can be there. So it's best, as you reacted very nicely in time, that should be the procedure. One, we should remember that there's what patient says, I always say that listen to the patient. And if you do that, recently one thing happened to me, I will tell you. I have never had this in my life. I've been practicing so long. A patient I did about 5 weeks ago, only 5 weeks ago, double vessel disease. And then patient came back for follow-up. 1 month I usually see them. And 1 week after I do the blood test, and 1 month after I follow up and see the patient with the hematological test. And he was saying that I was so good for 2 weeks or 3, then I started pain, and his pain is not going. I'm giving spray and all the medication he's been taking. And then I was not convinced, because I was really convinced he's suffering with the pain. Then he was not convinced to do a check angiogram. It took me half an hour to make him understand why I'm to do another angiogram. Yes, we could have done like CT angio, but that if we find something, we have to bring back and do the test again anyway. So he has finally agreed with me, and I found that both in-stent restenosis partial, along with one stent has got proximal stenosis and another one has a distal stenosis. Then I, just with the balloon I cleaned, and then I found another lesion which we that time we didn't see. It was a not that critical, but in 5 weeks time it became so critical, 80% stenosis. So we did that. We have implanted another stent, and in the meantime there was something going on in my mind. Why so quickly both the stents have had this, which I never had in my life. Then we sent for these clopidogrel test, resistant. There must be something wrong with that. Patient was swearing that I took every medicine as you said. And then we found that he is partially active clopidogrel, and that's why probably he had this, and he had another lesion as well. So these are the things we can find in our life, but it's better to listen to the patient, what patient says. It's very, very important. We shouldn't take it as an, oh, I've done it perfectly, if so quickly it shouldn't happen, there's so much antiplatelet I've given, all these things. So always listen to the patient, and if patient says and you feel, please check. That way you can save the patient life. Thank you, Mohsin, for giving me the chance to talk, and thank you, Aftab, again. Nice to see you. Thank you very much. Bye. Assalamu alaikum.
Madam, waiting Dr. Fatima Begum. Madam, do you hear me? Please unmute, madam. Yes, madam.
Thank you very much, Dr. Aftab, for your nice presentation. I really enjoyed your lecture. But I have a question to you. What your experience regarding the GP2A3B receptor intracoronary use during doing primary angioplasty?
All right. I think Dr. Fabita, again, this is a very, very practical and a wonderful question. I think, see, the issues is that the guidelines usually, or the guidelines, I would not say guidelines, the medical companies usually, they talk about the IV boluses. So most of the drugs are the on-label use mentions about the intravenous bolus followed by the infusion. But I think all of us have realized that, and there have been certain papers that have been presented, which also talk about the intracoronary use. So in our clinical profile, what we often do is that if the patient is in the, as one of our colleagues just talked about, the patient in the emergency and is going to be taken up for a primary plasty and is getting delayed, and if the patient we know is going to be taken within a period of say another half an hour into the cath lab, and we'll be able to open up the artery within another 20 minutes or so, then we don't thrombolize, but sometimes we do start an IV GP2B3 in the emergency itself and before shifting the patient to the cath lab. So in those cases, it is IV. But sometimes when you're doing a procedure and in the cath lab, you find that you have a big thrombus-laden artery, and despite doing all things, I mean, despite giving all the vasodilators and you've done a thrombosuction, but you're still not getting a good flow and you have a big visible, angiographically visible thrombus, then yes, we have used intracoronary GP2B3 as also without any major concerns. So I think the only thing that remains is that many of these GP2B3s are directly from the fridge. And then once you inject them intracoronary, you do get some amount of bradycardia and T-wave inversions. And one has to be careful with someone standing next to the defibrillator because you have your coronary wires there. And if you have a VPC, sometimes you could trigger an RNT and you can have a ventricular fibrillation. So intracoronary, all these medicines, when we're giving them, we just are a little careful that someone is standing with a defibrillator next to the patient because these cold medicines given into the coronaries sometimes can produce bradycardia, a lot of T-wave changes, and in an unfortunate patient, you could get a ventricular fibrillation also. But yes, I would agree with you, Dr. Fatima. We've also used intracoronary with good results, but a conventional way is still to give it intravenous in majority of the cases.
There is no recommendation. There is no recommendation of intracoronary use.
Yeah, that's what I said. The label use is still of intravenous, but then we do shift it to intracoronary when we see a large thrombus burden, or if you've not really loaded it, the patient in the ER itself. Yeah.
When there is no flow due to thrombus, do you use the intercoronary GP2B3 receptor, doctor?
Yeah, I think again, Dr. Fatima, I think it's no flow is a really a nightmare for any cardiologist, and there could be multiple reasons. It could be because of distal choking of your vascular bed with all these thrombi, or it could be because of a dissection that you may have created during your ballooning or your stenting, and a distal dissection beyond the stent may prevent your artery from flowing, even though your proximal stent is well open. So the protocol that we normally do is to use the same thrombus suction catheter or a micro catheter, go distal to the artery as far as possible, and then we inject there with a contrast, or to make sure that there is a distal bed that is visible. If you sometimes are unlucky, you may see a big dissection flap, in which case stenting may be the answer out rather than giving a lot of GP2B3 inhibitor. So yes, we rule out a dissection as one of the etiologies, and then yes, in addition to the other vasodilators, intracoronary dilzem or nitroprusside and nicorandil, you could also give GP2B3, and we have used it in intracoronary form in those aspects those days.
Are you using nicorandil routinely?
Routinely, well, not routinely. It is basically for no flow, slow flow situations. Otherwise, it's usually nitrocontin.
No, when there is no flow. When there is no flow,
yes.
you
Yes, it's one of the drugs that we use, madam, for.
It has no effect on blood pressure.
Not really. It does not cause so much of an effect on blood pressure, and usually the effect is pretty transient. So the doses that we give, it usually has a pretty transient effect, and the blood pressure is usually built up. So in cases, I mean, adenosine has also been recommended. So sometimes if there's a real bad scene, we put in a temporary pacer and give intracoronary adenosine also, and that's also been recommended for slow flow situations.
Nicorandil is not available in our country. Yeah, Interventional for use.
Right.
Thank you. An excellent question, madam.
Thank you.
It's a nice question. Excellent. Professor Mohammad Shahabuddin, sir. Professor Mohammad Shahabuddin from Sylhet. Thank you, sir, for late night with us from Sylhet. Thank you, sir.
Thank you very much. Thank you, Dr. Aftab, for your excellent presentation. It's a vivid presentation, excellent. It includes all the sectors from very beginning to the very end until. I want to ask a question. What is the recommendation of pre-treatment of P2Y2 inhibitor in addition to aspirin in primary PCI or invasive procedure without knowing the coronary anatomy? Is there any recommendations?
Yes, sir. So aspirin, yes. So we need to understand that, when you're doing a procedure, many of these patients in a primary PCI, aspirin is always preloaded. So we always load these patients with aspirin. And as I said, in a ST elevation MI, we often load them with the clopidogrel also. Clopidogrel or the other two, prasugrel or ticagrelor, based on their clinical presentation. Majority of the times it is clopidogrel. In case the patient is has a history of a previous intracranial event, or the patient is more than 75 years of age, we stay away from prasugrel, or the other drug that we often prefer is ticagrelor. Now, in case of an ST elevation MI, the question of knowing the coronary anatomy before the angiogram is not so much important, because in an ST elevation MI, CABG has a limited role, and it's usually plasty that is more important. I think when it comes to non-ST elevation myocardial infarction, where you don't have an ST elevation, sometimes there have been guidelines which now talk about, or the recent ACS guidelines of 2020 now talk about getting a coronary anatomy before loading a patient. So the guidelines now say that if you have an acute coronary syndrome, that is a non-ST elevation myocardial infarction, they say that please do not load with either a prasugrel or clopidogrel or ticagrelor unless you know the coronary anatomy. The reason for this is that once you load these patients onto one of these P2Y12 inhibitors, and the patient has a bad coronary anatomy which requires an urgent CABG, then your surgical results may be worse off in terms of bleed, or the surgeon may not take the patient up for surgery anticipating a bleed. But in an ST elevation, so we really don't have these guidelines. And in fact, you'd be surprised to say that even in aspirin intolerant patients, the guidelines have said for ST elevation MI that even for patients who are aspirin intolerant, the first loading dose of aspirin should be given. So you still give the patient 300 milligrams of aspirin, even if he's aspirin intolerant. Thereafter, you can continue with the the P2Y12 inhibitor. But the first dose of aspirin does not require you to have any blood test done. It does not require you to have an angiogram. So for the ST elevation MI, you could use any of these P2Y12. But for a non-ST elevation MI, I would agree with you, Professor, that the guidelines now talk about not giving the second P2Y12 inhibitor unless you know the coronary anatomy.
Thank you. Professor Amar Kumar Chowdhury. Professor Amar Kumar Chowdhury, sir. Sir.
Thank you, Mark, to ask me for few comment. So actually, I hear all the from beginning to now. Dr. Aftab is very known to us and very known face to our country. His presentation is very brilliant from A to Z, from basic to advanced. Thank you. Before starting my small comment, I like to my condolences to the death of our IPDI Chairperson Wadud's mother. We must pray for his Jan best. I like to comment on the Aftab brilliant and very brilliant presentation. That for the, I think in my life, I never seen any interventional cardiologist that does not show any case, any PCI or case in his or her presentation. But this is the exceptional presentation that without any angiographic or without any interventional activity, he presents the management of STEM very nicely, very nicely. Thank you. I have nothing to ask or nothing to comment anything. Thank you. It's very late. Thank you.
Thank you. Thank you, Professor Dr. Mohammad Saidur Rahman Khan. You've lost vast experience on primary PCI. Dr. Mohammad Saidur Rahman Khan.
Yeah, Dr. Aftab, just apart from talking about, because already everybody has told, I think you have become bored hearing that you have a very vivid lecture. So I'm not going to that part. I'm just talking about these things. I'm just seeing that and I'm observing this, that at least precisely more than 1 hour, relentlessly, without a single moment of hiccup, you have just given your lecture without a single moment of hiccup. So this intense energy, inside energy of yours, I think may God help you to preserve that one for the later days and years. That's a beautiful thing. That's your very good inert energy you have. Most importantly, just one thing, just I feel as a cath lab in charge, sometimes I feel that time is muscle, these terminology for the patients especially in Bengali populations in your country and in my country, this is very difficult, I know. But at the same time, being a Bengali, we have also this problem, being an intervention cardiologist, even our associates and our co-workers in the cath labs, they even sometimes may not understand that 5 minutes is so much important. So you have to be very much sharp enough to do that one. And of course, other than that, we don't have that luxury to have a separate cath lab only for that acute setting of cases. That's a different issue. But even before that, we have to feel the same way more intensely that time is muscle. And interesting thing is that once in a blue moon you may see, but sometimes you can feel that with especially grade 3 to 5, like what we say the HTB, that huge thrombus burden, especially for 4, 5 or 3 to 5 thrombus there. Sometimes that we as intervention cardiologists, we have to rethink not to stent the artery at that very moment, though it is very tempting to go for it. So that one is also very important, because whatever you give there, IC, GPI, or whatever you do, Nicorandil or blah, blah, anything you do, because you will see some cases, incessant thrombus. You can't do that one, and it will be so much that no reflow and slow flow will be there. at any cost. And so in that case, it's rather like defer STMI, though a small trial, but they are trying to tell that it's possible that not to stand at that very moment. So this is also very important for an intervention cardiologist to keep his nerve cool and to rethink that whether we'll defer it at that time. That is one thing. And you know, Dr. Aftab, that sincerely I'm telling for last 15 years in this intervention cardiology and in reading different guidelines, because you are projecting especially the 2017 ESC, but 2018 there is a myocardial revascularization guideline. And you will see that within that 1 year, there are some changes already happened there, like digital protection device, like thrombus aspirations, it become 3. Though Tapas is telling that, yeah, you can go for thrombus aspirations, but test and total is telling, no, it's not good. So lots of things, you know, that still there is a gray zone is there. Like what you say, that you are telling that 24 hours or 48 hours in the guidelines that they are telling. After that, you have seen and you have done. Because angiography, you will do whatever the thing is, that whether you are symbolizing it at the right moment or not, or whatever it is, or is come late presentation. Without knowing the coronary, we can't comment there that whether we will touch that one. Already the tissue is dead, myocardium is dead, so don't, but we have to do the angiogram. So we are doing the angiogram, and what is the thing? There is a small note there. If the patient has ongoing hemodynamic instability and angina is there, then in that case, that is not applicable. That don't stent it. So that's also a very important thing. And which patient has that sort of angina, and for what artery he has that angina, whether the culprit one or from the non-culprit one, because the culprit one has damaged the whole myocardium there. Only the echocardiogram, you can't do that one. CMR, yeah, it's also a very expensive thing, and not all the time it's not available. Viability test by other means, nuclear scanning or something, you know, it will take a long time. By that time, that myocardium will be thin and akinetic. So actually, we are not helping that way also. In cardiogenic shock, sometimes it's not that the 12 hours. They're telling the guidelines, previous guidelines, up to 48 hours, you can go for revascularization. So it is a different story there. And sometimes we are doing the CTOs. How it has become CTO? It has become totally occluded, but the ejection fraction is little bit preserved there, especially for the RC or the LCX. But that artery has been occluded once. And then we are seeing that by some way the collaterals has helped, and the viability of the myocardium has been increased. And so, and then at that time we are opening that one. So why you will wait for 6 weeks to see the viability again and to open the artery after STMI? That's a big question. Still no answer there. Why only 6 weeks? That's also a big answer. Why not after 2 weeks? Why not when the prothrombotic states has been resolved a little bit, the heart has become beyond the storm, and then you can do that one. So why not? But most importantly, after the complete trial, we can tell that this has been fixed. At least we are a bit relieved that we are not beyond the guideline doing these things, that during the index hospitalization, please try to revascularize the non-culprit arteries. Not at the same ad hoc time, but at least within the index hospital stay, if you see that those arteries are really has critical lesions. So still it's a maze, you know, we are working still a maze. It's something that every year we have to answer in a different way, maybe. So again, the interventionist discretion is there, but still really I'm puzzled that actually which way is the best way to treat a STMI patient. Thank you, Dr. Akhtar, again, that you have relentlessly, you have talked in such a way. You have a lot of energy, you know, guy. That's very beautiful.
Thank you. Dr. Ashok Datta, do you hear me? Dr. Ashok Datta? Dr. Ashok Datta? Dr. Khalid Jaman, yeah.
Thanks, Dr. Aftab Khan. In this night, I don't want to bore anything to say about your capacity or about your brilliant presentation. Rather, I want to put a very simple question. Is that by pharmacoinvasive approach of ST elevation MI treatment, we are giving benefit both fibrinolytic therapy as well as catheter-based therapy to the patient. If after fibrinolysis, you see during angiogram that the coronary artery, occluded coronary artery become patent and there is mild or no residual stenosis in 10 or 20% or 30% stenosis, do you want to put any stent in the affected coronary segment?
Yeah, I can, Dr.
There is
Khaled
good restoration of the flow and
Right.
there is little or no residual stenosis across the occluded segment.
Right, Dr. Khalid I think again, as Professor Saidur just talked, I mean, you people have been the doyen of cardiology in your country, and I think your experience definitely has greater benefits for us. And I think as Professor Saidur was saying that unfortunately, we learn many things only after you've burnt your fingers. So this slow phenomenon is something, as he said, do not stent when you have a big thrombus. Many times you have to have sort of burnt your fingers trying to put a stent there, and then you realize, become wiser that yes, with a big thrombus, you don't really touch these arteries there. And coming to your question, now again, again, the last slide, as I showed, we really don't know. We may think that we have assumed that we have known everything in cardiology, but again, we really don't know where we stand. And identification of a vulnerable plaque is something that we still are not there. So we still don't know which is a vulnerable plaque. So we still go by, as we say, an oculostenotic reflex. When we see a stenosis, we treat it. And then we have moved on from oculostenotic reflex to something that we call as physiological evaluation. In an acute myocardial infarction, if you have given a thrombolysis and then we have taken a patient for a pharmacoinvasive approach, unfortunately, as I said, we don't know which of these plaques, even if they're 20%, are likely to sort of have a reocclusion rate. But again, we go by oculostenotic reflex, and anything that is less than 40-50%, we probably would not stent it in the acute phase also, unless we have something that is an ugly looking. So if you have an ulcerated plaque seen angiographically, and we often see it on an eccentric plaque, you take two views. In one view, it seems that it's really jutting into the lumen. Then these are arteries that we know are a little worried that may close again. So it is the morphology that we see angiographically. But again, if you ask me, well, do we do an IVUS or do we do an OCT? Well, we really don't have the answers, Dr. Khalid, to say which of this is a vulnerable plaque. So again, I think our understanding about which is a vulnerable plaque is still pretty pathetic, and we still look at stenosis, which is significant to identify which of these arteries we open up again. I don't know. Really, I have no answers, and it'd be nice to have your comments or Dr. Saidur, his or Dr. Sufia Rahman's opinions to understand what exactly you are doing.
Dr. Aftab, even in Japan also, those who are doing every day, I think the time they are taking meals, more than that time, they are using IVUS.
Right.
For each and every PCI or everything. So, but even they are telling that even STMI settings, we don't like to go for IVUS.
Yes, yes, right. Professor Dr. Chowdhury, sir, you just Professor Chowdhury, sir.
Thank you. I'd like
the great clinician also, sir.
Yeah, I'd like to focus on some simple thing that we can really correct, rather than going for all these interventional controversies and the logistic support that needed for the patient. Some very simple things. As one of my take from your lecture is making the physician and the healthcare worker be aware about the symptom of the patient. Patient can have an atypical symptom. Patient ECG may not be the typical one. And at the same time, patient enzyme may be negative in some cases. But back in the mind, we have to keep there that there is always the possibility of having an acute coronary syndrome in that patient. That is one of the great my take from your lecture. My second concern about the pharmacoinvasive therapy, there is a concern, at least from my part, is we know teneptalize, the studies that has shown benefit over the non-pharmacoinvasive therapy is with teneptalase. But majority of the cases, in almost 98% cases in Bangladesh at least, we are using streptokinase. So streptokinase, as you know, it has got less revascularization capacity, and it has also got higher chances of getting rethrombosed. And whether the same benefit that we had extracted for teneptalize can be also be equated for streptokinase, I'm not really sure. My third concern is about the patient that comes to us after 24 hours. And there is a common mistake, or what I should say, there is myth that every patient after myocardial infarction should have a coronary angiogram, which is wrong. But in many centers, in the back of the mind of many cardiologists are there that we should make an angiogram to those patients, and it is being doing there. It is being doing. So little awareness is required when to do the catheterization and when not to do the catheterization. And as you have rightly said, that the viability, the zone of viability after 24 hours is not that clear. So I would rather go back to the old suggestion about when we are discharging the patient, we can have a stress test, especially with dobutamine stress and other things, which can also reveal the inducible ischemia as well as the viability, can still work therefore. And before the discharge, even if the patient shows some reversibility as well as viable myocardium, then we can have the intervention on that patient. I have another comment on lipid lowering drug. It's common scaring about the non-cardiologist in using the LDL cholesterol lowering drug. For hypertension, we had J-curve. If you reduce hypertension more, there will be more death. For diabetes, we have Nike curve. If you reduce blood sugar, then we have more death. But for cholesterol, we do not have that curve. And it is said that the LDL level of a child is about 30 milligram. And if we can reduce the LDL cholesterol up to 30 milligram, then we can have the endothelium of a patient with coronary artery disease similar to that of the bottom of an infant, as smooth as that. And in that regard, I think the main lipid profile that we have is predominantly triglyceride. And it has been shown that if we give anti-triglyceride drug during acute coronary syndrome, has got some beneficial effect, meaning that triglyceride have got some effect on inflammation and other things. So in that respect, if you see rosuvastatin and the atorvastatin has got more lowering effect on triglyceride. Maybe marginally it will benefit. So these are the issues that can be solved in this part of the world, I think. So when we address a patient with acute myocardial infarction, there are some simple things that we really can correct, that we really can communicate, and we really can formulate some guideline on that. You know, there are also issues about using morphine and oxygen and other simple things that can be well formulated and well circulated. So it has been a very, very extensive and very nice lecture on your part. We are so happy to have you with us.
Dr. Aftab, regarding Meskat sir talk, I have a question because Meskat sir is a very good academician and clinician and some conservative attitude. In our subcontinent, including your country and Bangladesh, delayed and within 12-hour streptokinase getting or not getting, low molecular weight heparin is getting or not getting, patient is coming to with mild symptom, with no symptom, with no hemodynamic derangement, with normal hemodynamic. In index hospitalization, whether we did CAG in every person, not angioplasty, to see the coronarity or not.
Yes, I think Dr. Amal, I think you made a very important point. With all due respect to Dr. Chowdhury, who has probably years of experience, and I do appreciate that we definitely are in depth to our physicians and our medicine specialists, because they are the ones who take care of all diabetes. They are the ones who see the patients first, even prior to us seeing the patient. And many times they are the ones who are first contacts with the patient. So I think Professor Chowdhury, as you said very rightly, so the other things, as you said, correction of diabetes, correction of lipids, I think these are equally important. Giving all the medicines is equally important. But the guidelines are very clear that you must know the coronary anatomy, because as Professor Saidur also said, see, the intention of doing an angiography, so every patient should get an angiography after an MI. So whether it is 12 hours, whether it's 24 hours, because unless we do an anatomy, we will not know what the outcomes are going to be. For example, you may have an LED or an anterior wall infarct where your LED may be all dead and gone. So you may do a anterior wall which is gone, but you may have a large dominant RCA, as Dr. Sufia Rahman also said, and I think one of my other colleagues also said, that you may have another artery which is critically blocked and that may not have presented at that time. But sometimes if you leave this artery alone, you may end up with a second MI once this patient goes home. So it's important to know the anatomy, because unless we know the anatomy, we may not be able to treat this patient accurately. And the important thing to know is that not every angiography ends up in an angioplasty. I think the fear for many of our patients is that if a patient has to go into the cath lab, means he's going to definitely get an angioplasty. I think we need to explain to them that just like you have an X-ray or a CT scan done in this COVID era, every patient is going through a CT scan. Every CT does not mean that the patient has COVID. It helps us to quantify this patient, which of this patient is sicker, and treat them accordingly. An angiogram has to be looked at that way as a test which will help us to quantify which patient probably needs a treatment, and probably help us to know the coronary anatomy. I don't know if that makes sense, Dr. Chowdhury. I think that is what I would say.
Maybe, but we really have to look at the guideline. As you have FFR in every center. At a time, got borderline lesion and other things, other issues when there can be overworked. Right. And I always follow the clinical guideline, which will lead us to the coronary angiogram. There are indications for angiogram that has to be followed very strictly.
Right.
That is
so the guidelines are very, very clear in chronic stable angina, sir. And I would agree with Dr. Chowdhury, as you said, it's for chronic stable angina. So when you have but for ST elevation MI, the treatment management protocols are very different. So for chronic stable angina, I will definitely agree with you. It's not that every patient who has angina needs to get a treadmill done, get an angiography done. You could do a treadmill, find out if this patient really has a high risk treadmill score, or if the patient has, as you said very correctly, do a dopamine stress echo and find out. So for chronic stable angina, I think the ball game is very different. But in acute MI, probably we are dealing with a different scenario where the guidelines are definitely in favor of an angiography for all. But I would agree with you, in chronic stable angina, we have the COURAGE trial and the other trials, which tell us that we may not need to do an invasive approach for all. Again, but if you look at the COURAGE trial also, the classification, yes, the classification into medical management or into the invasive arm was only after the angiography. So even in the COURAGE trial, which showed that there was a better result with medical management alone, the classification into medical management or the invasive arm was only after doing the angiography. So only when they had a blockage, which was less than 70%, that they put them into the invasive, the correct arm. But again, as I said, these are guidelines, and you are the best person who's treating your patients. Each patient has their own unique sort of financial constraints. They have their own mental constraints. They have their own geographic locations. And I would say hats off to all of you. Even in the limited situations, you are doing a wonderful job to take care of our patients. And Professor, I think it's always not the guidelines, but it's all your thing also that makes a difference in our treatment.
Thank you, sir. Hats off you, sir, Dr. Aftab Khan. I think an excellent session. We are running around 3 hours. We have to conclude because a long time, still 50% in the webinar, also 200 in the Facebook page. So thank you, everybody. You glad to know IPDI continued last 7 months without uninterrupted. Say more than 50 classes is going on. We are grateful to you, Dr. Aftab Khan, being with us. I think see you again next time with next session. Thank you, everybody. Thank you all the participants. Thank you all the panelists, especially panelist Professor Rahman, also senior brilliant panelist here. Dr. Aftab Khan, you few last comments for the budding cardiologist. You any comments for our budding cardiologist? Last comments for the.
I think again, as I said, guidelines are only there to guide us. They are not the gospel truth. And I think one has, as Professor Rahman and Professor Chowdhury and all of it's your clinical acumen that also comes into play. So it's important that we know the guidelines, because we need to know what is the best. And guidelines have, of course, been formulated with looking at multiple trials. As Dr. Saidar also said, Professor Saidar also said, guidelines keep on changing. What is good now may not be good in the future. So it's important to use your clinical acumen. I think it's better to be safe, know what is important. And I think learn from your masters. You have a talent. I mean, a lot of experienced seniors with you. And I think the juniors should also make use of the vast expertise that all these great legendaries have with you, in Bangladesh, and sort of learn from them. Make sure that you learn from others' mistakes rather than making your own mistakes. And I think most important is that treat the patient, as I said, do use the grandmother test. And that's what we do each time for each patient. Treat the patient as if it was one of your own relative. And I think that's what would be the best way to treat. Make sure that you do what is the best for your patient and best for you also.
Thank you, sir. Lastly, thank Abdul Vascular, the sponsor in this session, Abdul Vascular. But last but not least, Beximco Pharma. They are going last 7 months, given the job, the midnight with going on IPDI, Beximco Pharma. Thank you all staffs. And I think our next session On the 10th December, in the Masters Cardiologist, everybody, Professor Imad Sivan will talk on bifurcation session. The tremendous session, I think, on 10th December at 9 p.m. We'll meet you again. Till then, goodbye. Assalamu alaikum. Stay safe and take care. Aftab Khan, assalamu alaikum. Thank you, sir.
Assalamu alaikum.
Thank you. Meskat sir. Assalamu alaikum, sir.
Assalamu alaikum.
Mohsin sir, assalamu alaikum.
Assalamu alaikum. Thank you.
Allah Hafiz. Allah Hafiz.
Allah Hafiz. Allah Hafiz.